Good morning. I'm the Vice Chair of the OCA Board, and the meeting will now come to order. I'll note that this meeting is being recorded. So now if we can please do roll call.
Good morning. Dr. David Carlisle. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson.
Here.
Richard Kroenig. Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Molds. 6 present, 2 absent.
Great. Well, with that, we've established quorum. We do expect Dr. Carlisle will be able to join us a little bit later. So with that, I'd like to turn it over to Director Landsberg. Date, please.
Thank you very much, Madam Chair, Madam Vice Chair, and good morning, everyone. Welcome to the meeting. This is our new meeting location. We're here at the May-Lee State Office Building Complex, which will be the home of HCI's new office headquarters beginning this summer. For those of you who don't know, May-Lee was California's longest serving civil servant who died in 2023 at the age of 102 after working for 80 years after 80 years of state service with the Department of General Services. So come join state service. It's good for your health. So we're pleased to be here, and I just want to thank staff who's done a lot of work to get us ready to meet in a new location. In terms of our agenda today, we have 2 action items: a vote to establish a subcommittee for the selection of advisory committee members, and a vote to establish hospital sectors. And we will be taking agenda item 5A, the hospital sector data analysis, out of order after action 4A, so that we can have the information before the vote. And you can see our other agenda items here. We have we have data to present to you, discussion about our total healthcare expenditure regulations and some changes to the data submission guide, as well as an update on our cost and market impact review program. So moving on to my executive updates, I'd like to start by just expressing that our hearts are with all of those affected by the devastating fires in Southern California. And at the public meetings that I was at last week, I talked a little bit about California's response, but Secretary Johnson has been on the front lines, spent quite a bit of time down there with the governor and with others. So want to give her a chance. We know this is of big impact to all of you and to all of California.
Thank you, Director. And yes, have spent a significant amount of time over the course of this month with both survivors and everyone on the ground in communities supporting those survivors. And as with frequently with these events, it also shows the best of humanity in the giving and support, and people really leaning in and leaning forward to do so. So California Health and Human Services has a very robust component of the response, everything from supporting emergency evacuation and the temporary sheltering to getting food bank distribution and food supports, addressing skilled nursing facilities and both what they might need for repopulation, but also really leaning into what we can learn about emergency preparedness response and how we're continuously improving in the evacuation components of those setting types, as well as adult and senior care, et cetera. Flexibilities, you've seen a lot of executive orders from the governor in terms of giving flexibilities on access to prescriptions and other necessary resource for survivors as well. And right now we have disaster recovery centers, 3 today operating, where much of our department and resources are being offered to survivors. So the devastation is real. The recovery will be long, but we have a commitment from the governor and others to really expedite all processes and rebuilding community, with a recognition of particularly the community of Altadena and its historical importance for the state of California, and recognizing that there is an unevenness in people's ability to rebuild their homes and do that in an expeditious manner. You may have seen the governor is there today and has been there also through most of this month, and offering some great public-private partnerships, $100 million being announced, and again, showing that outpouring of support to community. So we will continue to be on the ground, really again, leaning into not only what we can do to improve our response systems in emergency, but also how we are really accelerating and expediting processes to recovery in communities.
Thank you very much, Secretary Johnson. And I just want to say I'm proud to be part of an administration that's been so responsive, that's focusing on equity. We know that Altadena was a historically African-American community because of redlining, and a very resilient community built there. And really appreciate that in our response and recovery, we're very much focused on those who are most marginalized. So we're asking questions about, we're concerned about immigrants being fearful about coming forward to seek support. We're providing assistance in many languages, and really thinking about seniors, people with disabilities. Our HCI staff is on the lines examining the skilled nursing facilities. 11 had to be evacuated. One was completely destroyed, another significantly damaged. Secretary Johnson was with our staff doing a site visit of a skilled nursing facility. So really appreciate also all the partners. We know clinics and hospitals and health plans and everyone are coming together to support Californians. In the midst of the fires, January 10th, it was a constitutional requirement for the administration to release its proposed budget. And so our Department of Finance director did so. And I just want to talk a little bit about some of the budget impacts to HCI. So the 25-26 proposed state budget is a $322 billion budget. Last year, the governor proposed a 2-year budget framework. There were a number of reductions made in last year's budget. And so this year's January budget does not propose reductions. We will note that the state has eliminated 6,500 positions and has operational cuts of almost 8% that impact OCA and HCI along with most other departments. In terms of budget components impacting HCI, we're very pleased that the budget includes a long-term sustainable funding for the Healthcare Payments Data Program, or HPD. So when the HPD was created, it was done so with a one-time general fund appropriation, and with those funds running out, it's time for long-term funding to support the HPD, California's all-payer claims database. So the budget does seek $22 million per year ongoing, and 47 staff positions to continue this critical data program. The budget also includes BH Connect, a very significant behavioral health waiver that was negotiated by the Department of Healthcare Services. And there's $1.9 billion for over 5 years to expand the behavioral health workforce serving Medi-Cal members, and HCI will have a budget change proposal on BH Connect in the spring about those resources. We also have a number of legislative BCPs, including implementation of hospital seismic safety and clinic building standards. And then I wanted to also mention the diaper initiative. The governor is proposing to provide a free 3-month supply of diapers for all California families with newborn babies to help improve maternal and newborn health outcomes. And the budget calls for HCI to administer this initiative. Staying on the topic of affordability, there's a proposal that'll be coming out in the spring around prescription drug affordability. Given the rising costs of pharmacy expenditures, the administration's continuing to evaluate the key drivers of prescription drug cost growth, including the impact of pharmacy benefit managers. And building on the work done here by OCA and with CalRx, we're exploring approaches to increasing transparency in the pharmacy supply chain and improve the affordability of prescription drugs in California. So thus starts the annual budget process in California. In terms of the Healthcare Payments Data Program, just two quick updates. We've reached a big milestone. The HPD Data Release Program has begun accepting applications for requests to access non-public HPD data from researchers. And we know there have been requests for updates on HPD, and our HCI, OCA, and HPD teams will be co-presenting to the OCA board about how staff are using the HPD. We'll be doing that. We plan to do that in our March meeting. And with that, I'll turn it over to Deputy Director Vishal Pagani.
Thank you, Director Landsberg. This month, OCA will present the following updates to our quarterly work plan. First, under items pertaining to total healthcare expenditures and spending targets, the board will discuss options to define hospitals as a sector, and may take a vote at this meeting. After this vote, OCO may need to follow up with the board in February with regulations effectuating the board vote on sector definitions. Later today, we'll cover more specifics on that timeline. This month, OCA will also provide further data analysis on hospitals to inform a target setting methodology, and we'll provide some options on hospital sector target values as a formal staff recommendation on or before February 21st. At the board and advisory committee meetings that are occurring this month, OCA will also discuss a draft revised data submission guide and accompanying regulations. Public comments will be received until the 31st, which is this week, and we'll take those revised. We'll take those comments and revise the discussion data submission guide further based on this feedback. The goal is to obtain approval on a regulatory package later this spring. And then lastly, the board will vote this month to establish in this meeting to establish a subcommittee to consider reappointment of AC advisory committee members and selection of new members. Shifting over to the cost market impact review program, both the board and the advisory committee are receiving quarterly updates this month on notices received under the program. Shifting over to the column for promoting high value system performance, in today's meeting, you'll receive an update on OCA's proposed quality and equity measure set. Your feedback will inform the presentations that we will continue to refine these proposals and come back to you in the spring. And now on the next slide, we projected out future topics beyond March. A key activity will be continued discussion on sector targets, the behavioral health investment benchmark, and quality equity measure set. We also hope to introduce the topics of equity and quality adjustments as they pertain to spending targets and spending performance. And then lastly, we'll provide a quarterly update once again on the cost and market impact review program. Moving forward, I'll now highlight select findings from the latest Centers for Medicare and Medicaid Services report on national healthcare expenditures. In 2023, healthcare spending reached a high of $4.9 trillion, amounting to an average of $14,570 per person. On a per capita growth basis, this is 7%, which is substantially faster than the growth rates of 4.2% in 2022 and 4% in 2021. The largest contributor to this growth reaching $7,065 per person. This marks a sharp rise compared to growth of 5.1% in 2022 and 6.8% in 2021. Notably, this category of expenditures that have the technical term net cost of private health insurance, which encompasses administrative expenses, taxes, and fees, grew by 12.5%, further driving overall spending increases in this sector. Medicare spending also accelerated, growing by 5.9% to about $15,800 per person, compared to a 4.4% growth rate in 2022. This growth was bolstered by the continued expansion of Medicare Advantage enrollment and higher spending on hospital and prescription drug services. Medicaid spending per person saw even sharper growth, increasing by 7.1% to roughly $9,500 per person, a significant rebound from 2.1% growth in 2022 and negative growth in 2021. In 2023, if we look at the overall insured rate, it reached a record high of 92.5%, the highest level in 6 years. This milestone was driven by strong enrollment in both private insurance and Medicare. The growth in spending is not solely tied to coverage expansion. Increased utilization and intensity of services also played a substantial role. Healthcare prices rose by 3%, consistent with 3.1% observed in 2022, but higher than the average annual growth rate of 2% from 2016 to 2022. And then when we break it down by spending categories, hospital care, which represents 31% of total healthcare spending, grew at a remarkable rate of 10.4%, a significant acceleration compared to 3.2% in 2022. This is the fastest growth in hospital spending since 1990. Physician and clinical services, comprising 20% of total spending, increased 7.4%, up from 4.6% in 2022. And then meanwhile, prescription drugs spending, which accounts for about a tenth or 9% of total spending, rose by 11.4%, surpassing the 7.8% growth that we saw in 2022. Overall, 2023 was a year of accelerated healthcare spending growth, driven by a mix of increased insurance coverage, higher service utilization, and rising prices. These trends underscore the challenges of balancing access to care with affordability. And now, as we do at every meeting, I remind the board and the public about our slide formatting key. The statute denotes several responsibilities for which the board has ultimate decision-making. We note that with the green arrow, and then yellow indicates areas where the office has decision-making authority. I'll now turn it back over to the chair to facilitate any discussion.
Great, thank you both for those updates. Any questions or comments from the board? Dr. Pan?
Thank you so very much. I appreciate the presentations. First of all, of course, I think my heart also goes out to the people in LA who are suffering from the fires. I actually had some personal friends who've lost homes in there. So certainly, unfortunately, an ongoing tragedy, and appreciate the work of the administration and supporting. I was going to ask about healthcare facilities, but I think you touched about that in your presentation as well. And we've seen in wildfires, of course, not only healthcare personnel being at the front lines trying to take care of people, but even as their own homes may be burning or damaged and their own families are trying to adjust as well. And of course, the facilities themselves oftentimes are affected and their ability to take care of patients as well. So again, appreciate that. Perhaps in a slightly more celebratory vein, since we're in the new Mei Lee building, I actually had the opportunity to meet her before. Amazing woman. I do want to recognize that tomorrow is Lunar New Year. Perhaps in the face of the various things going on, country, I'd make note, it will be the year of the snake. Snake represents wisdom. I know in the Western culture, we tend to look at it negative, but I also mentioned it's the wood snake. So that's which represents courage and resilience. So I think those are qualities we may need, we could use in the coming year. So I look forward to celebrating Lunar New Year despite and recognizing that there are a lot of people suffering right now. I did want to just touch on the national health expenditure presentation. Again, I really appreciate that. I think one of the things that's important to note is that, first of all, hopefully good news that we actually have a record high insured population. But that also means you have people who might have had deferred or delayed care who are now covered. We went through this phase when we implemented the ACA, although obviously this is much smaller scale. And so oftentimes there's an accumulation of care that services that are needed that because they're now covered that hopefully they're partaking of that they were delaying before. So what we see, of course, is most of the growth being driven by the increased numbers and intensity of services. And I think as we look at our, obviously certainly concerned about the costs, at the same time, we also have to recognize there are people with unmet needs. And so our efforts in trying to restrain costs should not be about denying people needed care. And so I think this presentation illustrates some of the challenges of doing that. I would also make note that as I was presenting in terms of the rate of growth in both private Medicare and Medicaid, we talked about percentage and then cited these numbers per person, but that's not the rate at which the growth was happening per person, right? Because after all, we said we have more people covered. Perhaps there's some more intensity that would drive some of that up. But I just want to be sure that we don't conflate the percentage increase. Medicaid grew by 7 points, or 9,502 per person, because the increase was not $9,502 per person. It was a 7% increase, but that represented the total average, if I'm correct, or no, is that the actual, that's the actual increase per person? Okay,
That's right.
all right. So, so that's per person covered?
So the CMS reports, they do present kind of an aggregate, like the 4.5 trillion overall. They'll present a rate for that. And then they also do the per capita growth rates.
Mhm.
So the ones we presented are per person.
Okay, all right. Just want to clarify, that's per person covered. Okay,
Yeah,
Right.
for the respective programs.
okay, for the select programs. Okay, thank you.
Anything else from any of the members of the board? If not, we'll take public comment on this update.
We'll now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually, please raise your hand. Those dialing in can press *5. When it's your turn, you will be unmuted. We also invite you to provide written public comment. The email is on the agenda for today. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I'll start with the individual at the podium. Please go ahead.
Beth Capel for Health Access California, and my apology to speaking to the back of several board members. It's a new setup here. We want to join with Secretary Johnson and Dr. Pan, recognizing the victims of the wildfire and the extraordinary measures made by both our first responders and our healthcare providers to address the situation, and by the governor to plan ahead for not only the immediate needs, but the longer term recovery, which we know from other fires is before us. Just a few other notes. We too join in celebrating the expansion of coverage. We would note that research done by UCLA on the early implementation of the ACA in California found that the unmet needs were addressed and people's care managed within 24 to 36 months. Unfortunately, most studies cite the study out of Oregon that only looked at the first 18 months, which is exactly when that unmet need is there before it's gotten fully managed. So we are concerned that another gathering on the other side of this continent will be rolling back those gains we have made both in covered California and Medicaid. We would also note with regard to the national health statistics that Vishal reported on, that when you look at what private employers paid as opposed to government employers, whether federal, state, or local, the increase in the employer contribution to private health insurance premiums for 2023 is 13%, more than 3 times the rate of inflation and far in excess of what the public programs or the public payers paid. That is why we are here, and that is what we will be talking about as the day progresses. Thank you.
Thank you. Looking virtually, seeing no hands raised at this time, going back to the podium. Seeing no one at the podium, that concludes public comment on this item.
Okay, thank you very much. Let's move on to item 3. Vishal, you want to add anything about the December minutes?
Sure. We just have the December meeting minutes, the minutes and any written public comment we've received since the last meeting have been included in your meeting materials and distributed.
I'll entertain a motion to approve the minutes from December. Rick, is there a second?
Second.
Let's take anything else from the board on comments? If not, we'll take public comment on the minutes.
We'll now take public comment on this item. Please limit comments to this particular item. Looking online, seeing one hand raised. Steve, please go ahead.
Good morning, members of the board and staff. This is Steve McDougall with CFT. As I look at the comments that came in late from the December 16th meeting, I find it interesting that the supermajority of them come from providers or those representing providers who have put upon the commercial insurance payers for this plan year astronomically large rates increases to our plans out there. And if I take a look at all of the comments and take them as a whole from the providers and their representatives, they just want to wallow and gouge us even further for more years to come. The time for reform is past due. Thank you.
Thank you. Looking to the room, please step to the podium. Seeing no one at the podium, looking back online. Seeing no additional hands raised, that concludes public comment on this item.
Okay, with that, let's, unless there's any other comments from the board, let's take a vote on those minutes, please.
Dr. David Carlisle. Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Abstain.
Elizabeth Mitchell. Aye. Dr. Richard Pan.
Aye.
5 ayes, 1 abstain, 1 absent.
The motion passes. Let's move on to item 4. Megan?
So this agenda item is a vote to establish a subcommittee for the selection of advisory committee members. We have Megan Brubaker, manager with OCA's Engagement and Governance Group. She will provide an overview of the solicitation and selection process.
Hello and good morning. Before we jump in, I just want to give a thank you to Board Member Pan and Board Member Mitchell for serving on this subcommittee for the past 2 years and working with staff so diligently to provide great recommendations for this board. So the first slide we have here is just an overview of the advisory committee as it is today. We have 28 members, 12 of whose terms end on June 30th. I will note here that when we originally established the advisory committee, we did terms that would end, half of the members' terms would end in 1 year, and then the other half would end the next year. But with the addition of members from the last year's solicitation, we are no longer at half and half. So that's why you see less here. And for this year, we will do solicitation. So that means opening up the applications starting next month through April. And there is always the option to reappoint the current members. You go to the next slide. Okay, and highlighted here in yellow are the 12 members whose terms are expiring on June 30th of this year. We have 2 payers, 2 representatives from hospitals, 1 representative from a medical group, 2 physician representatives, a purchaser representative, a healthcare worker representative, 2 consumer representatives or advocates, and then 1 from organized labor. Next slide. And this is just a reminder of what the statute outlines as the requirements for the advisory committee. So broad representation from consumer and patient groups, payers, fully integrated delivery systems, hospitals, organized labor, healthcare workers, medical groups, physicians, and purchasers. Next slide. And also in the statute lays out the acknowledged experience in healthcare economics, healthcare delivery, management, or healthcare finance and administration, healthcare technology, research and treatment innovations, competition in healthcare markets, primary care, behavioral health, enhancing value and affordability of healthcare coverage, or organized labor that represents healthcare workers. Next slide. And also, the advisory committee should reflect the state's diversity. So taking into the diversity in culture, race, ethnicity, sexual orientation, gender identity, and geography. So it represents the composition of the communities of California. Next slide. And here's just an outline of the timeline we have laid out for this year. So today we are discussing the subcommittee that we established, with hopefully voting to establish 2 members to provide recommendations. We will open the application February through April. And then April through May, we will meet with the subcommittee and staff to go over those applications and formulate recommendations for the June 2025 board meeting. And then in September 2025 would be the first advisory committee for these new or reappointed members. Next slide. And this is just some feedback we got last year. So there was a desire for a retiree perspective, which we didn't quite get to fill with the applications we received last year. Small business perspective. There was an emphasis on current or past involvement with the board or advisory committee, and we inserted a question last year to ascertain that information. And then we also got a request to update the optional demographic information, which staff is currently working on in our submission to align with the Office of Management and Budget Standards for maintaining, collecting, and presenting federal data on race and ethnicity. That was requested by board member Pan. So I want to pause here and see if you guys have any other additions to this list that we should be considering.
Anything from our prior committee comments on this matter?
I would just say I thought it worked quite well. I think the questions were effective, and the process for solicitation evolved appropriately as we learned. So I would just compliment the team, the staff, and the process. I think it resulted in a very balanced and representative set of committees.
Great. Dr. Pan?
Yeah, I too, first of all, want to thank the staff for doing an excellent job of compiling information for the 2 of us on the subcommittee. I also really appreciate the collaboration with my co-member, Elizabeth Mitchell, on this. Hopefully, as the board saw the result of what we've presented over the past 2 years, I've been happy with that. I've admit last year, frankly, we didn't have a retiree, partially because the solicitation did not really, we did elicit some nominees who checked off that category. I will probably repeat my general contention that although we did increase a little bit, I try not to make it too big. And also the meetings are public, just like our board meetings. So it doesn't mean someone who's not on the advisory committee can't actually present to both the advisory committee and the board and public comment and so forth. So, and by the way, as you see, when we get reports from the advisory committee, it's not like we're voting. So it's not like we need to, people are trying to get a voting margin. What we do is we get feedback from them. So it's more about the diversity of opinions on there as well. So, but I think it's been working well. We obviously, we want your input. And then of course, I guess the other question is, I'll just throw it out there. I would certainly be willing to continue in that role if the board chooses to do so with my good friend, Mrs. Mitchell, although I don't know whether she feels the same way or not, but I won't volunteer her. But I think I appreciate the work we've done before.
Well, let me say, as a member of the board and just our appreciation for the work of the subcommittee, and as well as staff, I think both the intent of the statute and the way the advisory committee highly functional. And so just appreciation to my colleagues on. There's any other interested colleague, I would entertain a motion to reappoint our colleagues to the subcommittee.
So moved.
Second. Ian?
Second.
I was going to nominate Ian. Um, I would nominate Ian, but I'm also happy to continue this decision either way. I think Ian would do a great job.
Okay, well, we have a motion on the floor now to reappoint our current members. So why don't we take that vote first? If we need to go from there, Elizabeth, we'll move. Oh, I beg your pardon. You're right.
Public comment first
Okay.
before voting.
Public comment, please. Thank you.
All right, we'll now take public comment on this item. Please raise your hand virtually or step to the podium.
Just to be clear, the motion on the floor is to reappoint Elizabeth and Dr. Pan to be the subcommittee.
Beth Capel for Health Access. I will leave it to the wisdom of the board and the board members to decide who the committee should be. I would say we had significant concerns 2 years ago about the composition of the advisory committee. We have attended every meeting, and as Dr. Pan notes, it's a public meeting, and Health Access has spoken in one way or another at every meeting, and we have been there from the beginning to the end. We note this because there are others who have failed to participate who are attempting to sponsor legislation in this area. And so we encourage them to take advantage of the public meeting of both the advisory committee and this board to do as we do and show up and testify. I would say that the mix of advisory committee members has been an extremely interesting one with different perspectives and different experience, and the frontline experience, which I know Dr. Pan particularly valued, has proven very helpful in thinking through the implications. There are some with broader policy expertise, and I think the addition of Dr. Shortell was helpful in that regard. There are others who represent the industry who have also a broader perspective on the healthcare industry, which is helpful. I would also note, in the spirit of the existing law, that the existing law speaks to some members having experience as a patient or caregiver of someone with a chronic condition or behavioral health or disability. That I know was language that was important to Dr. Pan as a legislator and is in the current law and acknowledges that role for patients. Health Access, as a consumer advocacy coalition, has worked with and represents all consumers in California and will continue to do so in this forum. Thank you.
Thank you. Continuing public comment, looking online, seeing no hands raised, going back to the podium. Seeing no one at the podium, that concludes public comment on this item.
Okay, let's move on to vote on the motion on the floor, please.
Dr. David Carlisle. Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
6 ayes, 1 absent. The motion passes.
Great. Let me thank my colleagues for agreeing to do this again. And we'll move on to, and we'll put Ian on notice. That, we might want to look at that again a year from now, but thank you for agreeing to do that. Let's move on to item 5A, please.
Thank you, Chair. So for this item, Assistant Deputy Director CJ Howard and Research Manager Andrew Farrer will co-present this item with me. I'll turn it over to Andrew.
Let's see. Is the mic working? Okay, perfect. Okay. Yeah, trying to learn from the best here. Okay, thanks, Michelle. So we'll begin by addressing two follow-up items from board member inquiries in December. So these involved looking at county level variation in cost metrics that OCA shared back in December. And then there was another request from a board member to stratify some of those metrics by urban versus rural counties. And so we'll briefly speak to those, but before doing so, provide a little bit of context around the hospital landscape in California. So we can go to the next slide here. So this is just a map showing just the geographic dispersion of different types of hospitals across the state of California. So there are 439 hospitals in the state, ranging from large academic medical centers to community-based hospitals. And you can see that they're distributed across urban and rural areas with particular densities in large metropolitan areas like Los Angeles, San Francisco, and San Diego. And in terms of the variation in, thank you, Megan. In terms of the variation in the types of facilities, there are general acute facilities, children's hospitals, psychiatric facilities, academic medical centers, and teaching hospitals, county hospitals, small and rural hospitals, critical access hospitals, and specialty care facilities that provide a range of specialized services, many of which are outlined on the slide that you see. Moving on to the next slide, we're going to provide a little bit of color as far as HCI's hospital annual reporting requirements. This is a little bit weedy, but it's important context just to help everybody understand some of the nuances in that hospital reporting. So here we have an overview of the subset of hospitals that have been granted reporting modifications to varying degrees. And so for context, on an annual basis, individual hospitals and hospital systems do report detailed facility level data on service capacities, inpatient and outpatient utilization, patient revenues and expenses by the type and payer, balance sheets and income statements. But importantly, not all hospitals are required to submit comprehensive annual hospital disclosure report data, either by virtue of statute or because reporting modifications have been granted. And so those modifications include the following types of hospitals. So first you see there would be Kaiser Hospital. So the 31 Kaiser hospitals are allowed to submit consolidated financial statements for their northern and southern regions, as well as limited financial and utilization data for its individual hospitals. Next are long-term care emphasis hospitals, of which there are 4 in the state, and they primarily provide, as their name suggests, long-term care. And so although each of these hospitals does submit full disclosure report data, HCI generally advises against their inclusion because it's not generally going to be comparable to its peer facilities. The next category would be psychiatric health facilities. We can mosey on back to the prior slide. All right, thanks. So these are county-operated psychiatric health facilities that are permitted to submit limited data by virtue of their small size, idiosyncratic patient mix, and then the type of care they provide. The next category would include Shriners hospitals. They are also permitted to submit limited data. And then the final class of hospitals that has reporting modifications granted are state-operated hospitals, by virtue of the fact of that idiosyncratic patient mix and the type of care provided. On we go to the next slide where we decompose that comparable versus non-comparable distinction. So of that 439 hospitals in the state, 367 would be considered comparable. So they provide comprehensive financial information to HCI. And then the remaining 72 are in that class of non-comparable. And here we break out that group by the Kaiser long-term care emphasis, PHFs, Shriners, and state hospitals. And so this will be important going forward as much of our analysis will focus on primarily comparable hospitals, but just want to make sure folks are aware of some of these reporting nuances in the HCI hospital data. And so I think for folks that also interact with various data products that HCI produces, they will almost always be subset to or filtered down to that set of comparable facilities. We can move on to the next slide. So now we can get to that first board member follow-up, which was oriented around understanding the variation across counties in terms of some of those cost metrics. And so what we did is we recycled some of the metrics that were introduced in December, as well as added an additional one. So those three metrics included inpatient net patient revenue per case mix adjusted discharge, a similar variant of that, just with a focus on commercial inpatient NPR per CMAD. And then the final metric is going to be commercial to Medicare payment to cost ratios. And so as previously noted, we're going to focus on those comparable hospitals for this analysis, excluding that subset of Kaiser hospitals, long-term care emphasis hospitals, psychiatric health facilities, Shriners hospitals, and state hospitals. I'll also note for the purposes of this analysis, we do weight the descriptive statistics by the number of discharges. So as you can probably imagine, across the state, there's a great deal of heterogeneity in the volume of patients that a given facility might see in a given year. And so weighting by discharges helps account for some of that heterogeneity. So we aren't treating a facility that sees maybe 15 to 20 patients in a given year to a hospital that may see 30 to 40,000. And we can go to the next slide where we'll be defining those three metrics. So the first one here, this again was presented in December, but just to recap. So inpatient NPR per case mix adjusted discharge is the amount of money a hospital generates for inpatient services, excluding charity care, bad debt, and contractual allowances. And it's adjusted by the number of hospitalizations to account for inpatient volume, as well as inpatient intensity for the services across all payers. The next metric is much like the first cost metric. It's, again, that amount of money that a hospital generates for inpatient services, but it is focused on what in the HCI financial data is considered third-party payers. Based on our conversations with subject matter experts within HCI, that category tends to comprise about 80% commercial patients, but there are other payers within that other third-party category. And so I'll note that this cost metric was not featured in that December board meeting, but we heard from a number of different channels that it could be important in really digging beneath the hood of that pooled metric of inpatient NPR per CMAD. And so we wanted to bring that to the board's attention. And then the final metric, commercial to Medicare payment to cost ratios, refers to the commercial and Medicare net patient revenue divided by commercial and Medicare costs. And so that ratio is going to compare the amount of a commercial payer pays for a medical service to what Medicare would pay for that same service, giving an understanding of how much more or less that commercial payment would be relative to Medicare's rate for that service. Okay, on to our descriptive statistics here. So we'll start with that first metric of pooled inpatient NPR and per CMAD. And so you can see here the counties ranked from highest to lowest. The statewide average for this particular metric was just under $15,000, with a low of $8,200 in Colusa County and a high of a little over $36,000 in Modoc County. We'll speak to a little bit of the geographic dispersion here. So based on an operationalization of the concept of rurality from the Office of Rural Health Policy, 5 of these 10 would be considered fully rural counties based on their definition. And there's a sort of a supermajority of these counties are in the northern part of the state. All right, we can move on to the next slide here. So this will be focusing on commercial inpatient NPR per CMAD. So the statewide average here was just a little over $21,000 with a low of $8,400 in Trinity County and a high of $40,000 in Santa Clara. We also, again, have those top 10 counties ranked. So we have one fully rural county of Calaveras, and then a fairly high concentration in the middle part of the state. So San Francisco, El Dorado, Yuba in the north, and then Monterey in the south. And we can move on to that final metric here of commercial to Medicare payment to cost ratios. So here we see that the statewide average was a little over 200%, so 205% from 2018 to 2022, with a low of 63% in Modoc County and a high of 420% in El Dorado County. And when we look at those top 10 across this metric, they tend to be in sort of that middle to northern part of the state, including Marin, El Dorado, and then further north of Tehama. But you also do see some parts of Southern California, including Santa Barbara. And then there are a handful of fully rural counties, including Amador, Tehama, and Nevada. So we'll now move on to the second follow-up item from December's board meeting, which centered on understanding the extent to which there's variation across urban and rural counties along some of these cost metrics. So again, we're going to focus on those 367 or so comparable hospitals. And also draw upon the Federal Office of Rural Health Policy's definition of a fully rural county, to just understand, so we're not reinventing the wheel here. The way in which they consider county rural is if it meets any one of the following criteria. So they are non-core counties, so they're neither micro nor metro areas based on the OMB's delineation. They're generally considered micropolitan counties. All census tracts within that county are considered to be rural. And then finally, the outlying metro counties don't have any population from an urban area of 50,000 or more people. And so just to give some context, of the 58 counties within California, 22 are considered fully rural based on that definition from the Federal Office of Rural Health Policy. And so what we see when looking at those urban versus rural counties in this particular 5-year time series, compared to those hospitals in rural counties, hospitals in those fully rural counties tended to have higher average annual growth in inpatient NPR per CMAD, higher average commercial to Medicare payment to cost ratios, and higher average operating margins. So we'll pause here just to see if the board members have any questions about these two follow-up items.
Ian?
Thanks for this. I just had a question on the definition of metrics slide from and the third bullet point there, the commercial to Medicare payment to cost ratio. When, as a purchaser, when I think of Medicare to commercial ratio or commercial to Medicare ratio, I typically think of that, we take a DRG, the basis of payment that Medicare would use, and we reprice the claim using the rates that Medicare would pay, and that's how we come up with the ratio. It sounds like this is a slightly different methodology. Could you tease out a little bit more detail about what this is?
We are very much standing on the shoulders of giants, your colleagues on the board in Rick Kroenig, so I might be inclined, so we're not doing violence to his work, defer to him if he wants to flesh out that question. I'm happy to piggyback on to add any additional color though.
Thanks, Andrew. Giants hardly. Yeah, this is slightly different. I mean, the data that is collected in the annual financial disclosure reports doesn't have DRGs. So this is estimating the payment to charge ratio for both Medicare and commercial and taking the ratio of those two things. It would, I think, probably be pretty similar to what you would get from the DRG kind of analysis that you're talking about. But, you know, I don't know that for sure. We also, actually, when I did this originally, I think I estimated payment to cost ratios for both commercial and Medicare. So we used the revenue center information. So hospitals have many revenue centers, room and board, lab, radiology, et cetera. We got payment to cost ratios in each of those revenue centers and then estimated, payment to or cost to charge ratios in each of the revenue centers. And we estimated the cost of services delivered to commercially insured patients and the cost of services delivered to Medicare patients, and then the payment to cost ratios. It turned out that using charges gets you to almost the same answer. And so that it's a lot of extra work to do that piece of estimating costs. And I think in what Andrew's done, you just use the charges part. Is that helpful or confusing?
No, I just wanted to say thank you, and just to try and restate so I'm clear. This is really the payment to charge ratio as opposed to cost as the way this is calculated here.
It's the ratio of the payment to charge ratio for commercial and Medicare, and it's an estimate of, you know, how much more commercial insurers would pay for a similar set of services if they were delivered to Medicare patients. And so it's kind of conceptually similar to your DRG approach, but it's a kind of different way of getting to that same estimate.
Thank you.
If Medicare would pay $15,000 for a given hospitalization, how much would commercial insurers pay for it? And on average, it's a little more than $30,000.
Elizabeth?
Thank you. I did read all the comment letters and heard all the complaints about all the measurement options, and appreciate that we've had the same challenges for decades now. But one of my questions is, have we considered using some of the newly available data from the mandated hospital reporting, the TIC reporting that is now available? We're actually working with a major vendor who has integrated those. So we're getting just more precision on actual pricing information because they are finally required to share it, and didn't know if we could integrate that. Similarly, there is a commercial total cost of care measure developed by Health Partners. It's endorsed by NQF. It's been tested in multiple states, and it teases out price and utilization. And that's just particularly relevant for commercial. So I just didn't know if we are considering these alternative measures and or data sources.
Thank you, Elizabeth. So as you know, there's kind of different compliance rates with the hospitals in terms of submitting the transparency data. So we're aware of that data, and we have met with some of the vendors that put those data sets together. But for the scope of this analysis, we we focus on HCI data because it's more complete for the several hundred hospitals that we're looking at.
I guess I would just, I mean, I understand that we're using what we have, but I do believe we're authorized to sort of look more broadly. And there are some either consultants or entities who actually are starting to use the data. Yes, it is incomplete, but there's progress. And it may just give us insights that haven't been available before. So just hoping we can look as broadly as possible to get past some of the historic complaints about the metrics.
Thank you.
Dr. Pan.
Yes, actually, just a clarification on the commercial to Medicare payment cost ratio, and appreciate the work of Dr. Koenig on this. So, of course, there are services that probably are very infrequently used by the Medicare population, like maternity care, probably, yeah. So are those excluded, or because you're not going to have, I assume, maybe I'm wrong, is there actually a DRG for maternity care in Medicare? And how do they come up with that number for Medicare? I mean, obviously it's very, well, let's say, I think it's based on my knowledge of epidemiology, it's probably an infrequent event. So,
yeah, it's infrequent, but people with disabilities deliver babies.
Yeah, no, they do,
and so there are Medicare DRGs for maternity. But as I think Ian's question, elicited, this particular method isn't using DRGs. Right? It is using charges. And, to the extent that the payment to cost ratio in maternity units is, if it were really different than the payment to cost ratio in radiology or laboratory, then this method would have more error in it. Again, the work that I had done, this was quite a while ago, using payment to charge ratios got to virtually the same answer as the more sophisticated payment to cost method. And the payment to cost method did treat each revenue center separately.
okay. And then being a pediatrician, children's hospitals, I mean, even for the same diagnosis, or is it you don't really use DRGs? Patients are very different, right? So how do you, and also, the Medicare population, you're right, you have people with disabilities and then you have seniors. Population is a little different than who the commercial is paying for. I don't know what percentage commercial is in over 65, but I'm just having, acknowledging that we're also taking different populations and trying to compare them. So how do you adjust for that?
Yeah, I mean, the basic comparison, and Andrew, you should tell me if you want to jump in. Starts with how much did it cost to provide services to a Medicare beneficiary, and if it cost $15,000 and Medicare paid $14,000, then Medicare is paying, 14 over 15,000% of cost. And if for another hospitalization, even if the services were different, the estimate is that it costs $15,000, but a commercial insurer paid $30,000, then, the commercial insurer is paying a little more than double what Medicare would pay for the same hospitalization. So the basics is, the estimate of cost, which is not, perfect. It's an estimate based on the information that's in the annual financial disclosure reports. But it does start with trying to get the costs for each service area and the charges for each service area. And so, you're comparing different services, certainly, but you're comparing them on the basis of what they cost, which is, a comparable thing.
Okay. I appreciate the explanation. I'm trying to get my arms around this as a measure, because one of the things is we're looking at these 3 different measures. On last meeting, we looked at, there didn't seem to be a high correlation between, it's like one, you got a whole different list of hospitals. There's some overlap, but I mean, there seemed to be a lot of different results that came out depending on which measure we used, which of course, is a little concerning just because, depending on which one we pick, we're sort of targeting certain ones versus saying that, oh, they're kind of more in line. So you see the same ones over and over again. The other question I have, and I recognize, because after all, I worked on the legislation, that we can't assign a hospital target to Kaiser hospitals, but I would also recognize that, for example, here in Sacramento, because Kaiser represents over half of all the commercial patients. So now, we're not going to assign Kaiser hospitals a cost target, but when we're trying to compare, like what should be, who's being expensive compared to someone else, somewhere Kaiser's got to fall into the mix, right? In terms of saying, well, this is where things, where sort of the average or the whatever for this particular area, given the cost and so forth, especially if they're such a large player in that geographic area. So I realize we have some limited, more limited data, but as we're trying to identify who the high cost hospitals are, of course, part of it is that, well, what makes them, our high charge hospitals, whatever, high payment hospitals. The challenge is trying to sort of say, okay, in this market, in this healthcare market, this is what would be considered reasonable. If you take out someone who's over half of the commercial market, since that's what we're really worried about, then it makes it a little harder to say, okay, well, the remaining market was who was in there and so forth, and should they, if someone else took out a good chunk of it, so is there some thought about how we incorporate at least the data we have on Kaiser into that?
Thanks very much for that, Dr.
Yeah.
Pan. And as you know, having attended the advisory committee meeting last week,
Yeah.
Kaiser came up a number of times. And
Yeah.
so Andrew or CJ will be covering, we did pull some basic Kaiser data just for a point of comparison.
Sure.
So we'll be covering
Okay.
that shortly.
Yeah, so I mean, I recognize one. And then the other issue that came up, and maybe this is for a little later, but just again, Kaiser is a system, right? And I know this also came up with the advisory committee since I was attending there, but some of the other hospitals are also, kind of more of a system, maybe not as big as Kaiser, and so how we start figuring that out, but I guess we'll touch on that later. But appreciate the presentation, appreciate the explanation, but I think we still have some questions that we need to get our arms around. Thank you.
So Vishal, could I maybe get you to comment more thoroughly on the advisory committee feedback we received?
Yes, we actually have a slide on that. But Andrew, how much more do you have to cover before we get to that?
If we can skip around and
Okay.
circle back.
Okay.
So yeah, we can be quite flexible in being responsive to the question on the floor, and
If
then
you
we
want to
can.
continue, Andrew, go ahead and then we'll pick it up.
Okay.
If you have more, if you want to go through the slides.
And Dr. Pan has a
Since we're all talking about urban rural, I know that you sort of highlighted on the measures, how many rural counties. But I also noticed that the other end were a lot of rural counties too. At least they seem to be rural, like Colusa and so forth. So maybe you can touch on that at some point. So it's, I know you did the average too, but it's not just at the top end or rural. There are also rural counties at the other end of the county spectrum.
Yep, yeah, the top 10 was just kind of a quick way of spotlighting, so we don't list all 58 on a slide. But yeah, totally take your point that there are low-cost counties among that array. All right, I think we can move on to. All right, perfect. So here we have, we'll just briefly provide a recap of December, where we presented the top 30 hospitals across 4 financial metrics, pooling that average from 2018 to 2022. As a reminder, those were a select and illustrative set of metrics, and they weren't meant to convey a methodology or any sort of recommendation from OCA on how to define a hospital sector or to establish sector targets. And to Dr. Pan's point, some of the feedback we received along the lines of that average inpatient NPR was that you are pooling some heterogeneous payers in that mix, and maybe you can sort of decompose that measure to really focus in on commercial patients in particular. And so along those lines, at last week's advisory committee, and here again today, we'll recap that inclusion of an additional spending metric of average commercial inpatient NPR per CMAD, following that same format from December, where we'll present sort of the full landscape with minimal exclusions across that top 30. And then we'll redo that same rank ordering with the following hospitals or facilities excluded: those critical access hospitals, PHFs, state hospitals, long-term stay hospitals, which we operationalize as having an average length of stay greater than 20 days, small hospitals, which we operationalize as having less than 100 licensed beds, children's hospitals, and then Kaiser hospitals. Okay, before we get to that top 30, just some high-level descriptive statistics here. For the statewide median across that 5-year time series, again, weighted by inpatient discharges, it was right around $18,000. For the top 30, the high was $107,000, and the 30th ranked hospital on that particular metric was $36,000. Okay, so here we have that top 15 on average commercial inpatient NPR per CMAD. So you can see as we sort of go through the list of characteristics, 9 have average lengths of stay above that 20-day threshold. 9 are also considered small. You have 3 teaching hospitals within the mix, 2 children's hospitals, specialty hospitals, psychiatric hospitals, public hospital, and a critical access hospital. As you can see through the various Ys scattered about, many of these hospitals transcend a single category. And there is a heavy emphasis in terms of the concentration within the Bay Area and Los Angeles. And this topic came up at December as far as, what's going on with some of these facilities. And so certainly the advisory committee members keyed into this. That first hospital on the list has about 15 to 20 inpatient discharges a year. And so you can get a great deal of volatility as a result of that rather small sample size. And then similarly, by virtue of pooling 5 years during a pandemic, you can similarly get some unusually large swings in inpatient NPR for commercial patients. So to take another example here, West Covina Medical Center's inpatient for commercial NPR range from a low of about $26,000 during that time series to a high of $160,000 at the peak of the pandemic. So just a caution about how both small sample sizes and a 5-year time series can produce some unusually volatile results on some of these averages. We can go to the next slide, which will have hospitals ranked 16 through 20 on this average commercial inpatient NPR per CMAD. So here again, there's a high concentration of hospitals with longer average stays. So 8 of those hospitals meet that criterion. 4 are considered small hospitals. You have 3 teaching hospitals, 3 public hospitals, and 2 specialty hospitals. So there's a bit of geographic diversity here. So you have hospitals ranging from Orange County in the south to El Dorado and Marin in the north, as well as some Monterey and Central Valley hospitals in the mix. All right, so now we will apply some of those exclusions, omitting some of those facilities that we previously discussed. And so here, with respect to those descriptive statistics, you can see for that top 30, the range is considerably narrower. So instead of over 100K, it's down to about 57 for the highest cost average hospital on that particular metric, with a low for hospital number 30 at 28,000. Excuse me. And the statewide median is $18,000 again on this particular metric. All right. So as a reminder, for readability purposes, as was the case in December, we're going to use some color coding to help provide some degree of ease of understanding of what's going on here. So the dark navy color is going to denote hospitals that are in the top 15 across a particular metric, whereas the lightly colored, let's call it light blue for lack of a better description here, is going to denote those hospitals that ranked in this, the 16 through 30 range on a particular metric. And so you can see here, 7 of these hospitals were also in the top 30 on commercial to Medicare payment to cost ratio. So to Dr. Pan's observation and others, you do see quite a bit of positive covariance here with respect to commercial inpatient NPR and commercial to Medicare payment to cost ratios. And once again, these hospitals don't neatly fit into one particular category. You can see a number of them transcend some of those attributes. And we can move on to 16 through 30 here. So again, 7 of these hospitals are in the top 30 on commercial to Medicare payment to cost ratios. You have a mix of teaching hospitals, specialty hospitals, and public hospitals. You also see some geographic distributions, including in Southern California, as well as the Bay Area and the Valley, and then one along the coast of Sonoma. All right, and I think we will now get to the question around advisory committee feedback, so I'll pass it off to Vishal.
Thanks, Andrew. So we covered this data this past week with the advisory committee. And some of the feedback is summarized here. And then at the end, I'll ask Dr. Pan if he has anything to add. Some advisory committee members suggested that some of the hospital data include more detail about administrative expenses within the inpatient net patient revenue metric. Also more detail about defining operating expenses within the operating margin metric. Another advisory committee member asked for more detail about the data elements used to compute average length of stay. A few members expressed concern over the number of psychiatric hospitals that fell within the data analysis review of metrics without specified exclusions. Others flagged the high operating margins of several psychiatric hospitals. A few advisory committee members expressed concern over using the commercial to Medicare payment to cost ratio as it pertains to the issue of comparability of services delivered under each payer, particularly the category of maternity care. Another noted that the ratio assumes Medicare payments are equitable across hospitals, and the member gave an example of 2 hospitals under the same hospital system that vary in their Medicare base rates, two essentially similarly situated hospitals. One member noted that public hospitals engage in self-financing for the non-federal share to draw down federal funds for Medicaid. And several UC, and noted also that several UC hospitals have children's hospitals embedded within them and thus warrants special consideration. And then lastly, another member noted that small hospitals have volatility and it may make more sense for OCA to focus on larger hospitals. Wanted to just turn it over to Dr. Pan as the observer for that meeting if he has anything to add.
Thank you, Vishal. Yeah, it was a robust discussion by the advisory committee. I think one of the things when we were looking at essentially the ratio with Medicare is to clarify in terms of the point that was made about hospitals in basically the same market or the same system that have different Medicare rates having, because that's a denominator. So how you divide it into it can have an impact. So I think that comment was made that probably worth looking into, being sure we have a good understanding of if, because otherwise, we're comparing terms, we sort of generally say, well, Medicare has a methodology and we're going along with it, but what factors actually influence that Medicare rate, because that becomes the denominator for the numerator, right? So you take a numerator dividing over that. So certainly, I think that concern needs to be addressed. But I think overall, as I said, it was a robust discussion. I think, and frankly, I think people are trying to be sure that whatever methodology we come out with is fair and understandable, right? And people need to know what to do to respond, right? So we can't. So being sure that there's clarity on how to essentially meet the goals that we will eventually set here as a board for people to be able to achieve what we're trying to get at. So again, thank you so much for that summary.
Elizabeth?
I think this might just be a clarification. I'm reading here that we are not allowed to put Kaiser in the hospital sector. We could create a target for the fully integrated delivery system sector that would apply to them. But is there also a reason we can't get their data to be part of this?
So that's right. They wouldn't be in the hospital sector, but we could certainly report on Kaiser hospitals because HCI collects that data on a individual Kaiser facility basis now.
I think that would be really important.
Yeah, I want to just pile on to that comment. I think whether or not we create a separate target for Kaiser or not, we should look at the hospital data that we have for Kaiser by hospitals. Because as Dr. Pan noted, there are markets where Kaiser is significantly influencing the market as well as having a lot of market share. And so I encourage us to do that.
Yes, definitely. We could. We'll take that back and kind of how that fits in with the public reporting OCA will be doing.
Thanks. So just on that point, I mean, I agree. It makes sense to kind of see what's available from Kaiser data, but as I think everybody knows, the notion of revenue to a hospital for a Kaiser patient is. I mean, these are decisions that Kaiser makes, right? For the most part, Kaiser is getting a capitation and it's allocating revenue to the hospital, to the medical group, but it's not as if the hospital is getting paid for each patient who is admitted or discharged. I mean, Kaiser does have some internal thing that kind of looks like that, but it's pretty different from what goes on in the rest of the world, I think.
Don,
Done.
would you put your mic up?
Sorry. Whether it's different substantively than arrangements, for instance, where a hospital owns a medical group and can be billing under either category.
Yeah, I mean, so it's not, I think it's not so different from a hospital or from a health system that's getting full risk capitation and is allocating money to various sectors, but that's a relatively small part, I think, of hospital revenue. It's a big part of revenue for professional groups. IHA, and maybe incorrectly, but IHA a couple of years ago said there was hardly any hospital revenue that came under capitation left in California. I think that's changed some, but it's still, most of the hospital revenue, I think, is coming through something that looks like a fee for service payment, even for HMO patients.
Dr. Pan, please.
Yeah, I think we should look into that at least. Well, in the Sacramento market, I don't know, maybe I'm not in charge of UC Davis, but we have capitation payments for essentially hospital and a whole set of, basically practices that are owned. So, and then of course, there's also, unlike Kaiser, there's also a portion, although that perhaps is fee for service, people show in the emergency room and so forth. So I do think that we might want to look into what kind of payment arrangements. We are actually going to be pushing value-based care here. That seems to be one of our goals as a way to try to contain costs. But I think it's important to see which systems may have capitation arrangements that may be a substantive part of their payment, and then I guess in some ways how that might affect the way their hospital behaves. We've gotten a letter from at least one health system in the Monterey area that says, well, actually we operate not just, a hospital and outpatient, we operate a whole set of clinics. And so and we're actually trying to save money by pushing stuff out into that network, which we also, so should we look at it as a whole, or should we look at only, and how systems may shift services to because of capitation, which is actually something we usually like, depending on what they actually did. So I think there's some complexities we look at. If it's really true that no, actually, and all these capitation arrangements, it only affects the medical group, not the hospital at all, then that would be different. But so I appreciate some clarity on that.
Yeah, I could take that question. So Dr. Pan's referencing a letter in the meeting materials from Salinas Valley Health, which notes that, it shows kind of the hospital margins or the margins for the hospital and the clinics and kind of how they operate as a system. So in the letter, Salinas notes that the hospital annual financial data reported to HCI only reflects services under their hospital license, and they operate clinics with separate licenses. So just to kind of recap some of the board's authority, it's to set and enforce targets for California healthcare entities. And the board's task is also to define healthcare sectors and spending targets. These targets could vary by sectors, which could be a type of healthcare entity. So we would acknowledge that there's no two healthcare entities that are identical. Many could be part of systems that operate multiple types of entities, including clinics, hospitals, and physician organizations. There's no definition in state law of what a healthcare system is. OCA's mandate is to set and enforce spending targets for healthcare entities, which are statutorily defined. So, individual healthcare entities that are part of larger healthcare systems may ultimately be subject to different spending targets. That is a provider organization may have a different spending target than a hospital, even if they are part of the same system. The statute contemplates this. And just to kind of, go back to the issue of the filings that for the HCI data. So those are based on licensed hospitals. There could be various combinations of arrangements. Some could have outpatient clinics operating on the hospital license. They could have separate clinics with their own license, or some clinics could be exempt from licensure. So if an individual healthcare entity were to exceed the target, OCA may consider the larger system in which the entity operates, in which the entity operates under, as part of our evaluation, and take that into account for any performance improvement plans. But overall, the way we're going to measure spending by healthcare entity is it's going to be based on how they're structured and licensed. And this could include, hospitals that do have outpatient clinics on their license. And then if the clinic's not on their license, but it part of the system, we could review those separately filed clinic financial reports. And that's all part of the back end performance improvement process.
Go ahead, Dr. Van.
Yeah, and I appreciate that explanation, Vishal. I think that, part of the reason Kaiser lobbied pretty hard for the provision for integrated because I think they recognize the risk of basically trying to take apart their system, and one can agree or disagree, which may create artificial barriers within their system to being able to basically, whether it's improve quality of care, some people could, or try to use the most cost-effective way of, et cetera. I mean, people have different make different comments about their motives and so forth. I'm just going to, but I think the idea is that, obviously consolidation is a challenge and we recognize that, but also integration and creating systems of care is something I think we're trying to strive for as we look at value-based care arrangements. So I just want to be sure that we're not taking a system and essentially taking chunks of it and looking, at only pieces of the elephant and then causing that system to have to respond in a way that actually drives up costs. So I'm not saying that certainly if you have a hospital, it's part of a system and that basically the system should be held accountable, right? And so you mentioned that this will happen on the back end, but I just want to be sure we recognize that Kaiser's not the only system out there, and they were able to get they for reasons that were actually kind of reasonable too. They got their piece in the legislation, but they're not the only organization that actually may have a capitation arrangement for a system that we would want to be sure that we're not basically tripping up. I mean, we need to look at them. They need to be held accountable, but we also don't want to put artificial barriers to efforts to both improve quality and lower cost across the system.
Yeah, thank you. I just want to say, obviously we read Salinas Valley's letters. We do all the letters and understand their circumstance. And I think the point we're trying to make is that we can only evaluate the data based on how it's filed. And so each entity has its own legal structure, and some choose to incorporate their more or less outpatient clinics. But we have to evaluate the data as it's filed with us. And as Vishal noted, there is no statutory definition of a healthcare system that would allow us to set a sector. And I think that's something we need to continue to look at. Rick.
Yeah, I mean, I understand the need to evaluate the data as it's filed, and I'm in support of the effort. I think I'm a broken record. I say this almost every meeting. I do think that it's very important that we work towards defining health systems and measuring spending by health systems. I mean, we are in California, and I think we would be doing a disservice to the people of California if we didn't work in that direction. I know that we cannot do that today, but I'm hoping that we can do that at some point in the future. Yeah.
We hear you. John.
Just not to pile on, but one of the things when we talk to our insurers about challenges, we hear about atypical referral patterns or excessive referrals, and capturing that is really important. And I think if you're just going to follow the strict lines that we're working under right now, that would be very hard to do.
Ian.
I guess I will pile on too. I think Don's and Richard's last points are very well taken. I do think, whether I agree or disagree with the way the statute was written for integrated delivery systems, Kaiser is substantially different from most other systems I'm familiar with because it is a fully contained payer, one distinct entity, whereas the other systems are often dealing with multiple payers. The importance of really understanding that Kaiser data at the hospital level, as well as the physician group and health plan level, I completely agree with. And it reminds me that I'm very glad that in the executive report that we have the ongoing funding for HPD, because we really need to lean in on that so that we have at some point soon here, hopefully, the ability, whether it's on basis of charges or the claims themselves, the ability to reprice the data as Medicare would pay it, as so many purchasers already do with Kaiser. And when I think of when it gets time to thinking about the integrated delivery system targets, I think a key data point for us will be how their hospitals compare with the hospital sector, how the other portions of the enterprise compare with equivalents.
Elizabeth?
Sorry, I'll be brief,
No,
but I do
fine.
think I'm just in total agreement. And to the extent that the hospitals are saying that their costs are higher because of primary care or whatever other relationships they have, we might be able to start understanding a norm. So Salinas is claiming that that is driving their costs, which are 476% of Medicare with an 18% operating margin. And I think it would be really interesting to see if that's the norm for a system or if there are efficiencies that could be had.
I just wanted to pick up on the point that Dr. Pan made, which is that the intent to understand how dollars are allocated within the Kaiser system is not in any way meant to undermine the integrated nature of what they're doing. And so I think intent matters here as well as transparency. And so I think our goal is to get to both. Okay. If there's no other comments from the board, we'll take comments from the public on this item. Yeah. Oh, I'm sorry.
Slide
Okay, go ahead.
about
Okay, about Kaiser, go ahead.
So this might belabor the point, but this since we all covered, it seems many of the board members had read ahead, but just so that the public is tracking, the advisory committee had asked why Kaiser hospitals aren't included in the sector definition and the sector data analysis. So we've included the relevant portions of the statute. The statute expressly excludes fully integrated delivery systems from board action to define them as a fully integrated or as a sector. And then we've included the relevant language about the board does have an authority to set a fully integrated delivery system target. And then the next slide, Andrew will go over some of the data we do have available for Kaiser facilities.
Thanks, Vishal. Yep. Sorry, I realize I'm the last thing standing between everyone's lunch. So I'll quickly move through this. We did want to try to be responsive to advisory committee feedback and provide whatever descriptive statistics we could based on the available data that Kaiser does provide at the 31 hospital level. It's 31 hospitals that operate. And so there was a change in their reporting structure beginning in 2021, which does enable us to compare Kaiser to other comparable hospitals in this particular case on a subset of those cost metrics. And so you can see here on that table below, compared to comparable hospitals, those 31 Kaiser hospitals on average tended to have higher average inpatient MPR per CMAD, lower growth from 2021 to 2022 on inpatient MPR per CMAD, and then lower average commercial inpatient net patient revenue per CMAD. And so this again ties back to what Rick noted, wherein Kaiser hospitals report income statements and balance sheets at the hospital level, but don't report cost and revenue detail. And so we're not able to compute some of those payment to cost ratios in the same way we are with some of those other facilities.
Okay. Anything more on Kaiser from the board? If not, let's take a public comment on the item.
We'll now take public comment on this item. Please raise your hand. If you're attending virtually, please step to the podium. Noting for the record, we have about 137 virtual attendees with the 3 hands raised at this time, so we will start virtually. Jeff, you should be unmuted on our end. Go ahead. Jeff, we're not able to hear you just yet. You might need to unmute on your end. All right, we will go ahead and go to the podium while we try and fix that.
Beth Capel for Health Access California. A couple of points to make on the data that's been presented to date. We very much appreciate the inclusion of the commercial NPR per CMAD. We think that starts to align with both the mission of looking at commercial, the costs of commercial, and we were struck in last month's presentation how blending together Medicare, Medi-Cal, and commercial NPR did not illuminate the discussion as much as we would have hoped, to be polite about it. We also appreciate looking back 5 years that deals with some of the idiosyncrasies of that COVID moment we went through. On 2 points that the board has discussed, we think it is important to look at the financial health at the system level as well, and we've made that point repeatedly. We recognize the constraints within the existing law and the current lack of definition and data, but we think it's important to get there for the reasons the board has discussed and that Dr. Kroenig has raised since the first meeting. We would also suggest that many systems are using the excessive revenue paid to the hospitals to facilitate consolidation and to further drive up costs. The literature on this is now quite clear. Consolidation drives up costs without improving quality. And we're extremely sorry to say the literature doesn't look at equity, but we bet if it did, if it's not improving quality, it wouldn't be improving equity either. With respect to Kaiser, the staff has provided you with much, but not quite all of the law. And since you know I'm fond of the law, it says clearly that the system, meaning the fully integrated delivery system, shall provide sufficient data and information comparable to other unintegrated payers and providers, including patient risk mix, to the office to enable analysis and public reporting of performance, including by sector, insurance market, line of business, and separately administered geographic service area.
2 minutes.
So, sorry. So you have, the office has the authority to compel comparable data, and we would encourage this board to take it for all the reasons that the board has discussed. Finally, we'll note again that because of the development of Los Angeles after World War II, there are a plethora of small hospitals in the LA basin, and failing to take that into account as we do the analysis is also failing to take into account the idiosyncrasies of California. I would also note that nobody thinks Monterey is in the southern part of California. It's in Northern California, and all of the analyses around, just as Tehama is, all of the analyses around the Sutter litigation make clear that costs in Northern California are substantially higher than those in Southern California. And indeed, the analysis you saw today also demonstrates that. Thank you.
Thank you. Looking virtually, we will try this again. Susan, you have your hand raised. I think you're unmuted on our end. Please go ahead.
Hi, my name is Susan Haley Barrett. I'm with the University of California Health, representing all of our 6 academic health centers. I wanted to echo concerns raised by the California Association of Public Hospitals and the California Hospital Association, and respectfully request the board delay action on hospital sector targets at this time. We respectfully request that OCA evaluate performance against the 2025 statewide targets, as well as data collection, reporting, and enforcement processes, before delving into sector targets. Furthermore, UC Health is concerned that the initial metrics used to identify high-cost hospitals neglects to address complex Medi-Cal financing mechanisms, which was referenced earlier on our how we do hospital financing for designated public hospitals. The fact that UC academic health centers provide a high volume of high-cost tertiary and quaternary care services for the most complex and high-risk patients, and the fact that 3 of our hospitals had children's hospitals embedded in them is salient. And we respectfully request that OCA must address these issues when considering metrics to evaluate these hospital costs. Thank you.
Thank you. We're going to pause for a moment. I think we're trying to control the volume just a little bit, but let's go ahead and take a comment from the podium now. Go ahead.
Sure. Thank you so much. Is the sound okay? Not yelling. Good morning, Secretary Johnson and members of the board. Amber Tervroot, representing Scripps Health. My comments will likely exceed the time permitted, so I'll submit a written copy to you. We too believe that sector target decisions are premature, particularly though because the impacts of earlier policies have not been analyzed. We do not dispute the collective goal and your charge for an affordability without sacrificing quality of or access to healthcare. Unfortunately, the targets set by this body are not achieving that because OCA's policies are being used by the healthcare insurance industry to impose conditions that are unattainable. With Medicare decreasing physician compensation by nearly 3% and implementing a hospital increase that is locked at rates below 3%, in addition to Medi-Cal, which is providing retroactive rate increases lower than the rate of the rising costs. These practices are going to be catastrophic for the healthcare providers in our state, but there are winners, the insurance companies. Since 2023, rates charged by insurers for covered California plans subsidized by the state have increased by an average of 17.9% for their members in San Diego County. So while premiums increase to the patient and the insurance companies restrict reimbursement to the healthcare providers below inflation, the profits for those insurers continue. Nothing addresses the costs that fall to the healthcare providers, and I know you discussed that a bit earlier today. Reducing payments to us does not make cutting edge cancer therapies less expensive. Our pharmaceutical costs have increased by 12% for our system. Our energy costs have gone up by 9% for our system. This is just this year. Labor costs have increased. The California healthcare worker minimum wage cost us $20 million in the first 12 months. Medical malpractice is up 39%, and these are just operating costs. This doesn't include the cost to comply with seismic mandates, which we've already invested $2 billion and nearly completed, but we still have an additional $1.5 billion on the horizon. I know my time is short, but we're not even addressing the need for, thank you. We're also not even addressing the need for state-of-the-art care. And I know that's not at the forefront of this board's policy-making charge, but it is the first thing people think about when they come to our hospitals or a loved one is in need of medical care. Thank you very much for your time today.
Thank you. So noting that we are trying to work on the volume for our virtual attendees, we will go back virtually. Daniel, you are next. Please go ahead.
Good morning, Chair Johnson. My name is Daniel Chibaya. I'm the Chief Operating Officer at Montage Health, and I'm here today to represent Community Hospital of the Monterey Peninsula. We also believe that sector targets are premature. Initial data published by HCI staff and shared at the December OCA meeting, in your follow-up advisory meetings, and even in this meeting today, highlighted just how problematic the study and analysis of hospital pricing is. Both HCI staff and OCA board members noted the lack of clear and consistent patterns. And notably, Community Hospital was absent from 3 of the 4 cost metrics presented without exclusion, which likely raised doubts among some board members or interested parties, given the rhetoric from special interest groups about Community Hospital over the past year. As a result, staff was directed to conduct a new analysis to identify disproportionately high-cost hospitals. And what resulted was a study in creative power, in the power of creative statistics. And once again, Kaiser was excluded, and several other acute care hospitals were excluded, and additional exclusions like the arbitrary exclusion of hospitals that fall anywhere below average state average number of admissions were also excluded, such that the new list of hospitals represents less than half the original size. The confounding new analysis arbitrarily examined 3 of the last 5 years rather than averaging all 5 years, and focused on the commercial to Medicare ratio instead of a broader net patient revenue per case mix adjusted discharge ratio previously utilized, all for the express purpose, in our view, of producing a curated listing targeting the 3 hospitals that have been maligned by local special interest groups since this group's inception. This analysis fails, in our view, to clearly, consistently, or impartially identify high-cost hospitals. There were no clear or consistent patterns between hospital performance on any of these measures.
2 minutes.
The focus on hospital margins rather than system margins also continues to be concerning, both ignoring need for hospitals to generate sustainable margins to support their communities and the economic realities of an integrated healthcare delivery system. In 2024, Montage Health system-wide net margin was 1.6%. We would welcome a commercial to Medicare ratio analysis of our entire system, not just the myopic view of hospital margins. OCA's definition of a hospital sector is wholly premature, coming years before statutory deadlines, and is absent of basic due diligence. Your actions have been arbitrary and capricious, aligning with the false narrative advanced by critics with vested special interest. While this approach may meet some political agendas of this body, this will fail the legal scrutiny it is certain to face. Thank you.
3 minutes. Thank you. Looking back to the podium, go ahead.
Hi, Ben Johnson from the California Hospital Association, representing over 400 hospitals across the state. As today's discussion showed, hospital finance is extremely complicated, featuring extraordinary and varying cross-subsidization across both payers and service lines. It relies on multi-year payer contracts, which sometimes lapse with implications for the rates that are paid. It sometimes includes payments for physicians and other professionals, but often does not, since only some hospitals can employ doctors under state law, and others financially support their on-call doctors in highly variable ways. It involves fee-for-service payments that generally get booked when services occur, but often include health system-wide capitation that then gets allocated across hospitals in ways that are entirely divorced from the fee-for-service based methodology that OCA is currently using. It includes payments that sometimes occur on a timely basis, but increasingly lag for years and are bunched up, creating enormous volatility in the revenues hospitals actually receive, and distortions in the data that are under review. All this complexity is being overlooked in favor of simple models, data that just happens to be available, at least for certain hospitals, and a Ptolemaic approach for determining which hospitals are high cost. Commercial net patient revenue per case mix adjusted discharges fails to account for enormous differences in underlying costs between hospitals, while the Medicare ratio effectively punishes hospitals that have worse Medicare reimbursement, making them disproportionately seem more expensive, even if their higher commercial reimbursements simply cover their greater Medicare shortfalls. These and other measures OCA has proposed for determining which hospitals are high cost all have major flaws, which can and should be seriously vetted before OCA makes decisions that could endanger hospitals' financial stability and ability to serve their patients. Thank you.
Thank you. Looking back virtually, Gary, you are unmuted on our end. Go ahead.
Good morning, and thank you very much. We just want to echo some of the comments that have been made both by the board and in public comment regarding the importance of looking at a system. I'm from Salinas Valley Health, and we provide both through the hospital and a system care to our entire population, which is around 80% under government payers. The questions are very complex on costs, and we think it's very important to make a distinction between those hospital-based outpatient services, which are on the hospital license and are reported in your data, but that data excludes the clinic-based or other hospital-based services. So looking at different hospital systems for what is on the hospital license and is what is either an alternative or, in our case, 1206B clinics, which do not fall on the license, is very important to look at the comprehensive financial picture for our system. Again, we appreciate that the board has acknowledged the importance of looking at the system, and we just hope that the board takes that into consideration, as pointed out in Dr. Radner's letter to the board. Thank you for your time.
Thank you. Back to the podium.
Janice Rocco on behalf of the California Medical Association. Listening to the discussion about the metrics we would use to figure out which hospitals are how high cost outliers, both at today's meeting and at some of the previous meetings, what occurs to us is that the sequencing matters. We'll have data for 2025 that we will have available to us that we don't have yet. And as we talk about who should be in and out of a definition of high cost outliers, there's not agreement yet what that would look like. Are we going to say that we're going to take into consideration the population you serve, the services you provide, whether you're serving critically ill children, whether you're a trauma center, whether you've kept open your labor and delivery unit, whether you do organ transplants, whether you have a higher need than other facilities to be administering high-cost drugs. It just seems to me that we should spend a lot of time together figuring out what does a high-cost outlier look like versus whose costs are truly higher because the population that they serve, or like I said, some of the services that they provide. And so that to me would seem to be the first step. And until you've done that step, I don't know how we would even contemplate where to set a separate target for the high cost outliers, because we haven't gone through the data to figure out what we're doing yet. So we do think it would be premature at this time to be on the path of setting the target until we've figured out which situations are high cost outliers for no reason versus they're providing services that the community needs in the way that they need them.
Thank you. Continuing public comment, noting for the record, we have about 139 virtual attendees and roughly 9 hands raised at this time. Going to Steve, go ahead.
Is this me or is there more than one Steve?
I'm sorry, Steve. Steve McDougall, go ahead.
Okay, cool. Members of the board, Steve McDougall with CFT, staff, chair, thank you for your time and this opportunity to speak. Arbitrary and capricious would be what providers, particularly those in Monterey County, do when it comes to pricing of their services. That's arbitrary and capricious. Regarding looking at whole systems, I can agree that taking into account margins of profit used to subsidize whole systems to provide services in regions where they would not otherwise be available is something to consider. However, to use margins of profit to consolidate the market and further drive up the cost, strangling household income budgets through healthcare rates, as they have been at the end of 24 coming into 25. For this to continue for another year or 2 or 3 is not sustainable. It is not sustainable in California, and it is certainly not sustainable in Monterey County. A reckoning needs to come, and it needs to come through statute. Change has to come, and it needed to come a decade ago. Please do not listen to the noise to delay this any further. Thank you for your time. Thank you for your consideration.
Thank you. Looking back to the podium, seeing no one at the podium, continuing virtually. Travis West, please go ahead.
Hi there, Travis West, Regulatory Policy Specialist with California Nurses Association. We thank the OCA staff for their work in performing this analysis and putting together this recommendation. CNA supports the staff recommendation to define all hospitals as a sector and adjust the sector target for selected facilities, and we encourage OCA to implement and begin enforcing this target as soon as possible. As mentioned in today's presentation in the advisory committee feedback, this option encapsulates the benefits of other proposals and would allow OCA to use the Community Hospital of the Monterey Peninsula, Salinas Valley Memorial Hospital, and Navidad Medical Center as test cases for applying adjusted targets at specific facilities below the broader sector target. Moreover, OCA should adopt the standard without exclusions for certain types of hospitals. While it may make sense to adjust the rate for some individual facilities, there is no formula or top-line metric that will accurately and fairly determine which facility should fall under an exemption without performing deeper analysis of how those facilities are operated. For instance, in reviewing financial measures, it's important that OCA distinguish how much of price actually goes into the cost of providing direct patient care or ancillary services, and how much is devoted to profit margin, administrative costs, marketing, executive pay, and other factors that are unrelated to the direct provision of patient care or related to ancillary services. In other words, while current prices and net revenue data may accurately reflect what is spent on care, those metrics presented by OCA and the advisory committee may not be an accurate reflection of the actual cost of providing direct patient care without determining how much price and revenue data are already inflated. Without further analysis, the metrics currently being discussed for defining exemptions have no method for examining whether hospitals are appropriately spending healthcare dollars on the provision of care and supporting the healthcare workforce, or whether hospital prices are justified. We therefore strongly encourage OCA to implement the all hospital sector target without baked-in exemptions or exceptions. Rather, the onus should be on each facility to demonstrate that an exemption is warranted on a case-by-case basis, using the metrics set forth in the staff's presentation as persuasive but not conclusive evidence. Thank you.
2 minutes. Thank you. Looking to the podium, seeing no one at the podium in the room, going back virtually. Mira Morton, please go ahead.
Good morning. Mira Morton with the California Children's Hospital Association. We would like to align ourselves with the comments of the California Hospital Association and ask the board to delay action on defining a hospital sector and setting lower targets for hospitals without understanding how the recently enacted statewide target will impact the system. The state's healthcare system is not too big to fail, and there are clear indications that it is not stable. From the closure of Madera Community Hospital to the continued closure of labor and delivery and pediatric units at community hospitals, all of which have impacts on the surrounding hospitals that must absorb those patients. When you regulate spending with too singular a focus on affordability, you inevitably impact access. We've seen this happen with the state's home insurance market, which was arguably much healthier than California's healthcare system is now when that rate regulation began. But after years of rate suppression, we now see a dramatic access issue in that insurance market that is devastating for homeowners and not possible to fix without substantial rate increases, the very thing regulators wanted to avoid. We urge the board to tread carefully here, making sure you fully understand the effect sector targets might have on access before you take additional action. Thank you.
Thank you. Looking to the room, seeing no one at the podium, going back online. Francisco, go ahead. Francisco, you should be unmuted on our end. You might need to unmute on yours.
Hi, can you hear me?
Yes, we can. Go ahead.
Okay, thank you. Francisco Rodriguez with the Monterey Bay Central Labor Council. We have over 80 affiliated unions in Monterey County and Santa Cruz County, representing over 36,000 members throughout both counties. And it is not premature to set sector targets now. Working families in Monterey County need relief. Employers need relief. We cannot negotiate contracts because of the high costs of medical or the high medical costs in Monterey County. We need to have relief now, and we can't wait 2 or 3 years, as was mentioned before. It is very important, and I want to thank the staff for the information, the data you've provided, and also the whole board for going to Monterey County. And again, I hope that you make the decision to set sector targets now. Thank you for your time. We really appreciate it.
Thank you. Looking virtually, seeing no hands raised, going to Kelly Brooks Lindsay. Go ahead.
Good morning, Kelly Brooks Lindsay on behalf of the California Association of Public Hospitals and Health Systems. California's 17 public healthcare systems, which include county affiliated facilities as well as the 5 UC medical centers, are the core of the state's healthcare safety net. Together, they provide 35% of all Medi-Cal and uninsured hospital care and have a mission and mandate to deliver high quality care to all, regardless of the ability to pay or insurance status. Public healthcare systems understand and support OCA and the Healthcare Affordability Board's goals to improve healthcare affordability. However, we have significant concerns with the development and pace of the hospital's specific sector targets and would urge that the board delay moving forward with this. Hospitals will already be subject to the statewide target that the board thoughtfully chose to phase in over a 5-year period. The board should allow for more time to evaluate healthcare entities' performance against the statewide target, finalize a methodology to measure hospital spending, work through data collection and reporting issues, and develop enforcement policies prior to creating sector-specific targets. We strongly recommend that the board follow a timeline that is more consistent with the statute and wait to establish sector targets. Additionally, as OCA and the board continue discussions on how to define high-cost hospitals, we have significant concerns with the metrics OCA has selected and the underlying data being used. This methodology resulted in a number of public healthcare systems appearing in OCA's list of the top 30 worst performing hospitals in the state. These metrics and data fail to account for the unique role public healthcare systems play in providing the non-federal share in Medi-Cal and supporting the financing of the services they deliver, as well as other important factors related to their financing structure, facility attributes and service lines, and case mix and coding challenges, among other issues. These concerns are outlined in more detail in our comments submitted to the OCA and the board on January 24th. Without acknowledging and or adjusting the data for public healthcare systems' unique financing structures and other issues, the lists OCA is presenting are not an accurate representation of their financing or high-cost hospitals in California, and there could be harmful impacts to the healthcare safety net. We look forward to working with OCA and the board to address these issues. Thank you for your consideration.
Thank you. Continuing virtually, Adam, please go ahead.
Thank you, Chair and members of the board. My name is Adam Zarin. I'm the Director of State Government Affairs, Leukemia and Lymphoma Society. Our mission is to cure blood cancer and improve the quality of life for patients and their families. We encourage the board to continue this important and urgent work because it is impacting Californians every day. As I've mentioned before to this body, many Americans, including Californians, avoid getting medical care or cut back on medicine because of high costs. Any increase in the cost of care will harm access, fairness, and public health. When patients face high healthcare costs, many will not start treatment. In fact, 4 out of 10 cancer patients do not begin treatment when they have high out-of-pocket costs. And on top of that, 42% of cancer patients use up all their life savings within the first 2 years after being diagnosed. Some borrow money from friends or family, but most end up with medical debt. High healthcare costs, especially from hospitals, are turning into medical debt, and this is a common reality for Californians. Take Chris, for example. Chris is a stage 4 cancer survivor who battled 2 types of lymphoma at the same time. One type of his cancers cannot be cured. He still needs ongoing treatment and regular checkups, but his medical debt continues to grow no matter how hard he tries to pay it off. When he was first diagnosed, he only had a 15% chance of survival. At that time, he wasn't worried about money, he just wanted to survive, but the costs of his care have added up quickly, and today he's still paying off his debt. He's been sent to collections, harassed by debt collectors, even threatened by lawyers. He fought hard to survive, but now he's burdened by the financial aftermath of that fight. In a health system where patients like Chris often have little choice and where hospital prices don't always match the quality of care or outcomes, we must work to keep care and coverage affordable and rein in the high cost of hospital care. So please continue this urgent work so that people can have access to affordable health care. If we don't, more Californians will continue to face crippling medical debt. Thank you.
Thank you. Continuing virtually, Dolores, please go ahead.
Dolores Yanagihara with Integrated Healthcare Association. I just wanted to make a comment. Elizabeth Mitchell had noted the Health Partners total cost of care methodology. And IHA has been using this methodology to measure total cost of care for provider organizations, payer types, geographies, and other sectors for the last 7 years. It works very well, and we feel it is worth considering its use to support hospital cost measures. Thank you so much.
Thank you. Continuing virtually, Bianca, please go ahead.
Thank you so much. My name is Bianca Blomquist. I am the California Director for Small Business Majority, a national nonprofit advocating for very small business owners and their ability to provide quality jobs to themselves and their employees. I am urging the board to act today, not delay, in adopting the sectoral targets, which will address the rising cost of healthcare for the more than 4 million small business owners that make up 99% of total businesses in California. Small business owners, as well as their employees, make up half of all ACA enrollees in this country. So we appreciate the opportunity to speak to you about how the rising costs of healthcare are impacting our state's most prolific job creators. The need for affordability among California entrepreneurs is growing. More than 1 in 3 small businesses report that it's been a challenge to obtain health insurance coverage for themselves and their employees in recent years that they can afford. 16% have reported they've considered reducing healthcare coverage in order to keep their businesses open. And entrepreneurs of color are more likely to indicate making this change. Moreover, we also know that small business owners tend to hire individuals and workforces who look like them. So the more we are able to bring these costs down for the entrepreneurs of color, women entrepreneurs, and other marginalized entrepreneurs in the state, the more we are helping their diverse workforces. Let's be honest that small business owners simply can't afford Facebook level benefits. So the decisions you make today will have sweeping impacts on the ability of Californians to start, run, and grow a business while providing quality jobs to California's diverse workforce. Costs must be contained to ensure the viability of small business owners in our great state. And I look forward to continuing working with the Office of Healthcare Affordability to make sure that these urgent reforms take place. Thank you so much for your time.
Thank you. Continuing on, Kieran, go ahead, please.
Hello, Chair and Board. Thank you so much. This is Kieran Savage, Sangwan with the California Pan-Ethnic Health Network. We represent consumers, particularly people of color, who are paying the exorbitantly high prices for healthcare and particularly hospital care. We will note, as some other speakers have, that hospital prices are the leading cause of medical debt. So the arguments that any additional pressure to reduce costs would reduce access, we find problematic given that access is already reduced due to the high cost of healthcare. We support a broad sector definition for hospitals, for high-cost hospitals, that allows the board to have flexibility in a rapidly evolving healthcare environment that includes potential major federal changes, deregulation, et cetera, at the federal level, and may necessitate California to move quickly to rein in particular hospital costs and prices. We also would encourage the board to do a particular deep dive on psychiatric hospitals. We noted in the data that staff presented to the advisory committee that psychiatric hospitals constituted many of the hospitals with the highest net operating margins. We are deeply concerned about that. We also know that this is a part of the hospital industry that is increasingly being bought up by private equity and is an area where consumers face particular barriers to care. Insurance denials for psychiatric hospitalization are very high, and consumers are often footing the bill, the entire bill for their hospitalization, which can be very, very expensive. This is also an area that connects to OCA's mission around quality, because we experience very low value, low quality care in many psychiatric hospitals. So would encourage the board, in the same way that you did a specific analysis of the Monterey industry, which is something we support, to do some specific work around psychiatric hospitals, particularly given the state's investment through Proposition 1 in these facilities and the need to make sure that they are working for consumers. Thank you.
Thank you. Continuing virtually, Elena, go ahead.
Hi, thank you. Hello, my name's Elena Santamaria, and I'm a senior policy advisor at NextGen California. NextGen California aims to uplift the voice of the youth in the state. NextGen surveyed the students we work with, and outside of student loan debt, medical debts were second top of mind for them. And healthcare costs are too high and have been unaffordable for families for decades. We encourage the board to continue its work and meaningfully address healthcare costs. More recently, NextGen has heard of a healthcare story that was shared with our organization. Jess is a mom and her son was diagnosed with cancer at a very young age. Luckily, she has health insurance, and her out-of-pocket cost last year was $4,000. However, the total cost of her son's care amounted to $1.1 million. The system is broken, and someone is bearing the cost of the cost of that care. NextGen urges OCA to continue to maintain the course to make healthcare affordable for people. Thank you.
Thank you. Noting at this time, we have no additional hands raised virtually and no one at the podium. That should conclude public comment on this item.
Okay, let's move to item 4B. Is anybody going to present here? Anybody else going to present, Michelle?
Yes, CJ and I will co-present this item. So I'll hand it over to CJ.
All right, we can go to the next slide. Good afternoon. My name is CJ Howard, and this is Deputy Director in the Healthcare Spending Targets Branch. So just a recap from last board meeting in December, OCA presented the following options to enable the board to establish targets to address high-cost hospitals. The options focus again on how to define sectors. The options that we presented included wait to define sector targets for performance year 2027 or later, to define the Community Hospital of Monterey Peninsula, Salinas Valley Memorial Hospital, and Natividad Medical Center as a sector, and establish sector targets for those facilities, to define a sector based on facility attributes and financial measures, and lastly, to define all hospitals as a sector and adjust sector targets for select facilities. Moving on to the next slide. To reiterate again from December, if the board does intend to proceed with sector targets effective for calendar year 2025 or performance year 2026, OCA recommends the board to define all hospitals as a sector. If defined as a sector, hospitals would be subject to the statewide target unless and until the board adjusts the target for all or a specified subset of hospitals within the sector. This option enables the board to respond timely to facilities with spending trends that do not advance consumer affordability. The next slide, I'll do an overview of some of the more pertinent statute to this exercise. So the board shall establish specific targets by healthcare sector, including fully integrated delivery systems, geographic region, and individual healthcare entities as appropriate. The board shall define healthcare sectors, which may include geographic region and individual healthcare entities as appropriate, except for fully integrated delivery systems. The board may adjust cost targets by healthcare sector, including fully integrated delivery systems, geographic region, and individual healthcare entities, when warranted to account for baseline costs in comparison to other healthcare entities in the healthcare sector and the region. The setting of different targets by healthcare sector shall be informed by historical cost data and other relevant supplemental data, such as financial data on healthcare entities submitted to state agencies and the Healthcare Payments Data Program, as well as consideration of access, quality, equity, and healthcare workforce stability and quality jobs. On or before October 1, 2027, the board shall define initial healthcare sectors, and sectors may be further defined over time. And not later than June 1, 2028, the board shall establish specific targets by healthcare sector, including fully integrated delivery systems, geographic regions, and individual healthcare entities. The development of sector targets shall be done in a manner that minimizes fragmentation and potential cost shifting, and that encourages cooperation in meeting statewide and geographic targets. Sector targets adopted under this subdivision shall specify which single sector target is applicable if a healthcare entity falls within one or more sectors. Moving on to the next slide. So OCA's recommendation is to define all hospitals as a sector. So some considerations in pursuing this. Based on 2020 CMS data, nearly 40% of healthcare spending in California occurs in hospitals. The approach for measuring hospital spending will be different from health plans and other provider types that rely upon attributed TME growth or total medical expense growth. Establishing hospitals as their own sector aligns with measuring them differently. The board can define all hospitals as a sector, while in tandem, OCA can continue to refine its hospital measurement approach. For inpatient spending, OCA will use the HCI hospital annual financial data submitted by hospitals to measure inpatient net patient revenue per case mix adjusted discharge. And for outpatient spending, OCA is evaluating a measurement approach that would consider the varying levels of resources associated with different outpatient encounters, for example, emergency department visits versus outpatient surgery. I'll hand it over to Vishal to cover some advisory committee feedback on this proposal.
Thanks, CJ. So our advisory committee met last week, and we covered these options with them. Many advisory committee members supported option 4 and the flexibility it provides the board in establishing targets for high-cost hospitals and the ability to address consumer affordability. Some members noted that option 4 allows the board to accomplish the intent of options 2 and 3 and provides flexibility in a dynamic environment that may include rising involvement of private equity and potential deregulation at the federal level. Other members suggested that Monterey hospitals might be a good test case, and the onus should reside on the facility to tell OCA and the board if they need a different target, or should be excluded. Some members suggested revisiting, whatever targets are set and adjusting them over time. Other members suggested setting sector targets by hospital categories rather than by individual entities. The member gave an example of considering a class of hospitals, such as all psychiatric health facilities or all academic medical centers. In response to that member's suggestion, another member noted it may be problematic to subject all hospitals within a particular health hospital category to the same target, and indicated preference for option 4 because it would allow you to address outlier hospitals. One member suggested that the same target value for everyone in the sector, and if the target's missed, OCA could take a retrospective look at their performance for if there's a justification for exceeding the target. Some members expressed concern over the pace of setting sector targets when hospital spending measurement isn't fully developed, and the need for more developments around enforcement. So just wanted to turn it back over to Dr. Pan, since he was the observing board member, if he has anything else to add.
Thank you so much, Vishal, for that presentation. I think pretty much covered it. I guess one of the underlying themes in many of the comments and in the discussion is that the methodology is still a work in progress. And I think, as was pointed out, we've even had this discussion here in the board. The outpatient portion is still up in the air, so we don't really have a methodology for that. We proposed one. We kind of said, well, that doesn't seem like that worked very well because it just took the inpatient and so forth. But I'll get into all the details. So I think there's some uncertainty in terms of the methodology that would be used. And I think the other theme that also came out, and I appreciate, again, the summary of the comments, is that, in the original proposal, it sort of said, option 4 said define all hospitals as sector, but then adjust the sector target for selected facilities. Exactly how that adjust the sector target for selected facilities would happen and what parameters is still yet to be defined. And at least the measures that were presented people did comment on, and I think we've commented here that you got a lot of variation there, right? In other words, it isn't all consistent. You don't have the same hospital showing up over and over again. So I think there's going to be work to do on the methodology that still needs to be done. Can it happen in parallel? Possibly. But certainly I think that seemed to be a common concern, combined with the desire to act swiftly. So by many people on the advisory committee as well. So I think we got to figure out how to navigate those two desires. Thank you.
Elizabeth?
Thank you. I have a question, I guess, for Dr. Pan or staff. Did any of the folks who are just suggesting that we just move more slowly because of uncertainty around methodology have constructive alternative proposals?
Want me to answer?
You're welcome to, Dr. Pink.
Sure. Yeah. So I think that in terms of the specific proposals, I think certain ideas were thrown out, but by particular individuals. But I think they do identify that there are gaps, and actually, frankly, it's similar to some discussions we've had here too. So I believe that, and again, obviously, the advisory committee is a diverse group, but I do think that people, people want to move. People want to move quickly, but also people need to have some idea or certainty about how we're going to identify these people, and frankly, people need to be confident about that. I said there's some missing pieces. I think that's the thing. People do recognize there's some missing pieces that we need to work on in order to, aside from assigning hospitals as a sector target, to because obviously the next step is going to be, okay, well, what target are we going to establish? And you can see in the comments, right? But I think that if which hospitals are going to get a different target than everyone, than let's say the global target, right? Is all the hospitals going to go except, and so how's that going to be determined? Is a question out there, right? And that's back to the methodology.
Rick?
I mean, Elizabeth, I think asked a very good question, and I think I heard the answer was no, that there weren't any specific suggestions of what to do. Is that
Not collectively, but different ideas were thrown out.
Could make the suggestion that we go around the room as board members and just get a sense of where people are today, given all the presentation by staff, the considerations of different options, the feedback we've gotten from the advisory committee, the public comments we've heard.
Before that, can I just ask one question of
Please.
clarification on slide 25? The middle bullet, if defined as a sector, hospitals would be subject to the statewide target. Is even if they're not, even if we were decide to decide not to define hospitals as a sector, they would be subject to the statewide target. Is that correct?
Correct. So all healthcare entities of which hospitals are a subset are subject to the statewide target that the board has already adopted.
Yeah.
So,
And so defining them as a sector, though, is what's needed to be able to define separate targets for subsets of the sector.
correct. And if I might, Madam Chair, just make a couple of comments. One is that if the board chooses to act today, and we can pull up the proposed motion for the board that's been suggested by staff to define all hospitals as a health sector target. So again, the steps would be that if the board were to vote affirmatively on that motion, then the staff will go forth and promulgate regulations. We, after lunch, have some suggestions about how to approach setting the target itself. And we would come back, staff will come back in February with a recommendation about how, some of these questions, which again, we very much encourage stakeholders to come forward with specific suggestions. And I just want to acknowledge there's two different methodologies. There's how you choose the hospitals to identify as the high cost sectors, and there's a different measure, how you measure the hospital spending going forward. I think there is largely consensus on how you measure outpatient spending. We're still working on, on inpatient. Thank you. We're still working on the outpatient side. I just want to acknowledge the staff has done a lot of work gotten closer and closer and worked with some stakeholders and board members to try to get to how to identify the list of high cost hospitals with this data. But the board does need to act today to allow us to move forward. So the board could, if the board chooses to act today, we will go forward and promulgate regulations, and that will give the board the option to adopt sector targets or not. Obviously, you're not beholden to adopt the high cost hospital sector target, but without identifying hospitals as a sector, we couldn't move forward.
Dr. Pam, you have a question?
A procedural question. So because the motion itself is simply to define a healthcare, that's the healthcare sector, that's all hospitals. The methodology, we also have authority over the actual target, but do we also vote on the methodology that will be applied?
No, so that's what I'm saying is that if the board chooses to define hospitals as a sector today, the staff will come back with a recommendation, with a proposal about what the methodology is to identify the high cost hospitals. As you know, we have to publish that for a 45-day comment period, and then the board could act after the 45 days at either the April or the May board meeting.
On the methodology.
On the methodology and the target.
Yeah, but I just want to specifically ask that.
Including.
Yes, we would, obviously we vote on the target, but also we vote on the methodology after we go through the regulatory process, correct?
Correct.
Okay,
thank you.
Okay, any other questions on the motion? Actually moved yet, but I want to make sure everyone's clear about that. Okay, Rick, can I get you to thoughts?
This seems like a no-brainer. Hospitals are a sector. They're a big thing, a big part of healthcare delivery. I think all the concerns and questions about how to identify high-cost hospitals and how to set targets for them are difficult, but we will come to them. As I've said probably 20 times in the 2 years, I also would think that the most important sector to be looking at are health systems. And I have a little concern that in identifying hospitals as a sector, it will take our attention away from that. But I'm confident that the staff and supported by my fellow board members that we won't do that. Sort of hospitals are a big sector, and it makes sense to me that they be considered that way.
Okay, thank you, Dr. Pan.
Yeah, I appreciate some of the concerns that people expressed about about the method, about essentially an absence, or not a total absence, but about methodologies and so forth. But I also think that this is to allow us to step forward and work on that. The other piece I hope I appreciate, and we are the previous discussion about health systems, that while we are defining hospital sector as a target, I would actually urge the staff to look at, because he said on the back end, we need to, in terms of doing not only the methodology, which will potentially assign different cost targets, what's going to happen on that back end, right? How are we going to look at things on the back end, recognizing that we do have, what we don't want to do is disrupt systems that actually may be working well, right? I'm sure there's systems that aren't working well, but we don't want to disrupt systems that are working well as well, and affecting whether it's access or quality of care that those systems may deliver. So this is, to me, I hear the concerns about lack of certainty about the methods and the methodology. We hope to, the board has another chance at that when that comes forward to look at that. But I also hope in the process of developing the methodology, we also are setting some parameters for what's going to happen at the so-called back end that hopefully can also incorporate some of the systems issues as well, to be sure that we're, whatever the actions that we take as a board and the office, again, we want to hold people accountable for high costs and especially excessive costs. I think more importantly, excessive costs. But we also don't want to basically disrupt the ability of people to get access to care. So I certainly hear people's frustration with costs, but so far no one has said, well, I'm willing to not have access to highly technical, highly advanced care in exchange. As well.
Don, anything you want to add?
Not much. I mean, if I understand this correctly, it's essentially a procedural vote to start the work that people have pointed out needs to happen, and that anxiety ought to be addressed by additional work on methodology and sector targets in this space. So I can't think of a reason not to do that.
Good job. Yeah.
Yeah, hospitals meet any common person's definition of a sector. That seems obvious. I do want to address, though, we started this meeting talking about the NHE, the huge pace of growth in especially commercial employer-sponsored health coverage. The last board meeting I was able to attend, 2,500 hotel workers were on strike in San Francisco because their employers were proposing to terminate their health plan. That strike resolved after 93 days that people were going out without incomes, facing foreclosures, and so forth. They won the money they needed to preserve their health plan, so that's good. That also means that $4.25 an hour within 2.5 years, $4.25 an hour less will be going into workers' pockets, simply to pay for the increased price of healthcare, and nobody's the better off for it. And I do want to address those who express concern about our pace. I also have concern about our pace. It's too slow, and $4.25 is life-changing for people who are cleaning rooms or cooking food. I also want to point out that the National Health Expenditures data shows hospitals eat up 31% of the whole pie nationally. In our slide 27 here in California, it's 40% of the pie. So it really drives home the outsized impact that the hospital sector has. So of course we have to define it as a sector.
Thank you, Elizabeth.
Thank you. I think the corollary to Ian's important point about the impact on wages, similarly and relatedly, we have members who are manufacturers saying that their company will not be profitable unless we address healthcare costs, that it is being baked into the cost of any good they are producing. So it's on all sides. I think this brings us back to the focus of this body, which is affordability for the people paying for care. So, and again, it's hard to argue that hospitals are not a sector. I think it is quite straightforward. And if Dr. Kronick says it's a no-brainer, I think that's a pretty important endorsement. And I completely agree. I think the pace is actually too slow. And if there were constructive alternatives to consider from the industry, we would certainly welcome those. But hearing that there aren't any other than slow down, I think we should move forward.
Thank you, Secretary Johnson.
Thank you. I appreciate the comments of fellow board members, and just again, appreciation of the advisory committee and all who have brought additional thoughts for consideration in this conversation. And also want to thank the staff for continuing to dig in. I think I agree that as I look at this, right, this is a first step, and we have more work to do in going further to look at how we might make any differentiations within the sector going forward. So noting that this is not the end, but to the points Elizabeth just referenced and made, right, there is a urgency in really addressing the overall issue that we have been charged to meet. So I appreciate, again, all the work that's being done to it. And I think in terms of the comments back on the speed in which the board is meeting, please keep on bringing those alternatives, other ideas, data points. We encourage, I think, that additional engagement as we are considering the totality and the nuances of various issues that people have raised. So just welcoming that continued input.
Yeah, I will just say that I'm struck that our industry colleagues, in raising their concerns around what a high-cost hospital might be, there may be very good reasons that this board would consider legitimately that a hospital is high cost for X, Y, or Z reasons. But if we don't start to collect the data on hospitals to understand that, then we're always got excuses about why we can't do it now or because we don't have a perfect methodology. And so in addition to all the urgency issues, which I completely share, I see this as really an opportunity to begin to understand how these hospitals work and why some hospitals legitimately, for whatever reasons, numbers of reasons or complications of reasons, may be an outlier. And I think we in the public would want to know that and understand that. And where there are not, and they're just simply high cost, this is really what this board was meant to do. So I really want to appreciate the input that we've gotten as a board, the work of the staff, and I'll entertain a motion to simply define hospitals as a sector for the purposes of moving forward with our methodology.
So moved.
Second?
Second.
Okay, let's take, I think, public comment on this.
We'll now take public comment on this item. Please limit public comment to this agenda item. We'll have a general public comment period at the end. If you'd like to make a comment, please step to the podium. Looking online, noting for the record, we have about 125 virtual attendees. We will start with the individual at the podium.
Beth Capel for Health Access. We support the motion. We oppose delay. Consumers are denied access today because of high costs. You heard from the Leukemia and Lymphoma Society and for others about the impact of medical debt. You have seen the studies where half of Californians delay or skip care, including doctor visits, prescriptions, lab tests, and more because of cost, and half of those Californians get worse. Everyone here within the sound of my voice knows that the people that are hurt the most are people who are, excuse me, who are making less than $150,000 a year, which I will remind again this board are 80% of California families. Most Californians live on far less than $150,000 a year. Affordability is a huge issue. It's why we're here, and we oppose delay. We appreciate the discussion of the board about whether there were constructive alternatives. We've attempted to participate in that, and we're sorry to say that others seem to be only interested in stalling for as long as possible. And for that reason, we support the measure. Thank you.
Thank you. Looking virtually, Steve McDougall, please go ahead.
Chair, members of the board, staff, and those that can hear my voice as well. Don't let those trying to make perfection the enemy of relief to the consumers of California. Give me a break. I'm going to quote someone earlier. This is a no-brainer. This delay, confusion, oh no, is bunk. Time has come past due to get the ball rolling on this work. And I appreciate your efforts and those behind it to get it done. When I reported about what happened with mixed sig in Monterey County in December, subsequent to the meeting on December 16th, one employer group was hauled in to the Human Resources Office where they were asked, how are you going to pay for this invoice for these unexpected bills that we received as the jacking up of prices at the end of last plan year by providers, in particular in Monterey County, is crippling the workers of Monterey County and across California in many places. Enough is enough. Let's get going on the work. And I support you in your efforts. Thank you very much.
Thank you. To the podium, go ahead.
Hi, good afternoon. Anate Miller speaking on behalf of the California Association of Health Plans, or CAP for short. CAP is pleased to see OCA's commitment to addressing high-cost hospitals in the greater context of the office's mission, which is keeping healthcare affordable and accessible. Acknowledging that time is of the essence, we support a sector definition that would allow OCA to set a target sooner rather than later, with the flexibility to adjust for select facilities. We believe recommendation number 4, as presented today, is best suited to accomplish this goal, as it would allow for a broad target at the outset, starting in performance year 2026, and then for high-cost areas like Monterey, for example, the OCA board could adjust the target further as appropriate. To that end, we encourage the OCA board to proceed with option number 4. Thank you.
Thank you. Looking virtually, Ben, go ahead. Sorry, Ben Eichert, go ahead virtually. Sorry, Ben.
Can you hear me?
We can't, go ahead.
Great, thank you. Benjamin Eichert with the National Union of Healthcare Workers. I want to echo the point made by Board Member Lewis and really underscore the fact that high and continuously rising hospital costs limit our ability and the ability of many other unions to negotiate for improved wages and benefits for our members. And it's because healthcare costs take up an ever increasing share of employee compensation, with the result being that everyday working people are fighting as hard as they can to earn enough to support their families, but each struggle requires more and more sacrifice for less and less gain, if there even is any at all. We believe that the need for reform is urgent. We support the recommendation and urge prompt action. Thank you.
Thank you. To the podium.
Hi, Ben Johnson with the California Hospital Association. California's hospitals oppose a leap first, look later approach to establishing a hospital target. Today's action is taking place nearly 3 years ahead of the statutory deadline, contravening clear statutory intent that OCA and its regulated entities work collaboratively and learn together, rather than fragment and cost shift under sectors that are set without proper consideration, study, and input. With this action, OCA would take a key first step towards setting one or more hospital sector targets, and yet OCA has not analyzed or reported a single year of total healthcare expenditure data. It has not compared segments of the healthcare field on standard financial measures so they can make data-informed decisions around multiple somewhat natural sectors that the hospital field could be broken into. It is not dispassionately assessed drivers of healthcare spending so they can understand areas where spending may be warranted on complex care and where it is low value. It has not determined how hospital spending will be measured and has not assessed any entity's performance against the statewide spending target and whether it is reasonable and attainable in this financial climate. Ultimately, what we are asking for and ultimately proposing is a more sound and judicious process, rather than one that prejudicially targets a field that is not right now trying to recover from the enormous operational, financial, and psychological strains of staying open 24/7, saving lives during the COVID-19 pandemic. I think this action undermines trust and collaboration toward shared goals of improved affordability for all Californians. And so we ask that the OCA board embrace a more judicious approach than what has been proposed to support OCA's efforts to develop its core functions and to make decisions informed by data and careful consideration, including with input from the field. Thank you.
Thank you. Looking back virtually, seeing no hands raised at this time, noting for the record, we have about 123 virtual attendees. Looking to the podium, seeing no one at the podium, that concludes public comment.
Great. Let's take a vote, please.
Dr. David Carlo. Dr. Sandra Hernandez.
Aye.
Dr. Secretary Kim Johnson.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
That's 6 ayes, 1 absent.
Okay, why don't we adjourn for lunch? It's 12:45. We'll come back at 1:15.
We could give people.
Till 1:30? Let's go to 1:30?
1:30 is great. Thank
Okay,
you so much.
we'll reconvene at 1:30. Thank you. Okay, good afternoon. We're going to reconvene the OCA board meeting. After lunch, we should do roll call, please.
Dr. David Carlisle. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson. Here. Richard Cronick.
Here.
Ian Lewis.
Here.
Elizabeth Mitchell. Here. Dr. Richard Pan. Don Molds. 7 present, 1 absent.
Okay, so let's continue on with our agenda. We are on item 5B, sector target methodology. Sean?
Yeah, thank you, Chair Hernandez. Assistant Deputy Director CJ Howard and I will co-present this item. CJ?
All right, good afternoon. So now that we've established hospital or taken steps to establish hospitals as a sector, and one of the things that we had discussed is the idea of potentially setting differential targets for disproportionately high cost hospitals. And so we'll focus some of our attention today on that exercise. And first, we'll discuss potentially how to identify disproportionately high cost hospitals that would merit a lower target. And then how to determine sector target values, so the actual value setting exercise. So we'll present options for each of these and solicit board input. And then at the February board meeting, OCA will present recommended target values, and the board would discuss the OCA's recommendation at the February board meeting. A 45-day public comment window will open on February 25th. The board would then have until June 1st to set targets for 2026 and could set targets for 2026 or for beyond 2026 at that time, just as the board did for the statewide target when it set the target for 5 years. So in the next slide, in this section, we'll describe different approaches for identifying disproportionately high cost hospitals. So our guiding question is how to identify disproportionately high cost hospitals that may merit a lower target value. We have 3 potential options in mind that we want to discuss. Option 1 is a repeat outlier on a unit price as measured by the commercial inpatient net patient revenue per case mix adjusted discharge. The unit price represents actual money and dollars and/or dollar amounts, accounts for the amount and intensity of care delivered, which better isolates the price per unit of inpatient services for commercial payers. Option 2 is a repeat outlier on relative price as measured by commercial inpatient net patient revenue per. My talking points are off, so pardon me. A repeat outlier on the relative price as measured by commercial to Medicare payment to cost ratio. So this is the commercial payments relative to Medicare payments. Medicare is chosen as a benchmark due to its nationally consistent pricing algorithms, which includes cost-sensitive adjustments, for example, wage index, teaching status. And then option 3 is where we do a repeat outlier on both of these metrics. The next slide. So commercial inpatient net patient revenue per CMAD refers to the price per standard unit for commercial inpatient care. The measure's advantages are it provides a consistent estimate of inpatient prices. It may be calculated for almost all hospitals, and it is more directly applicable to commercial cost growth and targets. In terms of limitations, the measure is that it is limited to inpatient revenue and is more sensitive to coding sensitivity. For the commercial to Medicare payment to cost ratio, this refers to the relative price comparing cost coverage of commercial to Medicare coverage. The measure's advantages are that it provides a clearer understanding of commercial payments based on a standard national benchmark, Medicare, and it includes inpatient and outpatient revenue. Some of the limitations of this measure is that it is not an appropriate measure for hospitals with a low Medicare or commercial revenue. As well, Medicare may pay some hospitals differently for the same services. Go to the next slide. So before showing the set of hospitals identified as high-cost outliers across the different options, we first present averages both within year and across the 5-year time series to help illustrate how the outlier hospitals compare to the broader population of comparable hospitals. As was the case in the prior analyses, we once again weight these descriptive statistics by the number of inpatient discharges. So from 2018 to 2020, the average commercial inpatient NPR per CMAD was between 20.6 thousand and 20.9 thousand. And the average commercial to Medicare payment to cost ratio was 207%. In 2021, the average commercial inpatient NPR per CMAD was 21.3 thousand, and the average commercial to Medicare payment to cost ratio was 197. In 2022, the average commercial inpatient NPR per CMAD was 22,000, and the average commercial to Medicare payment to cost ratio was 204%. And across the 5-year time series from 2018 to 2022, the average commercial inpatient NPR per CMAD was 21.1 thousand, and the average commercial Medicare to payment to cost ratio is 205%. Next slide. So we're now ready to lay out option 1, which is the repeat outlier on unit price that uses the commercial inpatient NPR per CMAD as the core measure. Here, OCA removes hospitals for which comparable financial data is not available. So as Andrew was discussing earlier, this is the Kaiser hospitals, long-term care emphasis hospitals, psychiatric health facilities, Shriners hospitals, and state hospitals. The repeat outlier approach recognizes that the 5-year period from 2018 to 2022 includes a pandemic. So instead of computing a hospital's pooled average over the 5-year period, we're looking for repeat outlier status in the 3 out of the 5 years. And so a hospital could have 2 out of those 5 years where there's could be high, but as sort of a grace period to allow to make sure that we're capturing repeat outliers. Based on feedback from the advisory committee as well as stakeholders, OCA recognizes that a hospital needs to have a non-trivial shares of revenue from different payers for cost metrics to be credible. With that in mind, OCA applied a 5% floor on revenue from commercial and Medicare payers. Finally, advisory committee members suggested 1, focusing on hospitals that are significantly affecting the cost of care, and urged caution with small hospitals that are more likely to have volatility in their costs. So OCA used an inpatient discharge threshold to ensure any hospital level cost measures are not artifacts of small sample sizes. So with that background, 23 hospitals would be considered repeat outliers on a unit price for meeting those criteria. So the unit price, they were in the 80th percentile, for their inpatient NPR per CMAD in 3 out of the 5 years. Their payer mix threshold of at least 5% for Medicare and commercial pay, and that their inpatient discharge threshold is above the statewide average. And so you could see here that 23 hospitals meet the aforementioned criteria. Applying a stricter cost outlier threshold instead of the 80th percentile, if we went down to the 85th percentile, 15 hospitals would meet the criteria. And if we use the 90th percentile, would yield 10 hospitals. So option 2 draws upon a similar intuition as option 1, but uses a relative price metric as the basis for identifying the outliers. It's the commercial to Medicare payment to cost ratio. Once again, OCA removed hospitals for which comparable financial data is not available. 23 hospitals would be considered repeat outliers on relative price for meeting all of the following criteria. So on the relative price metric, they were in the 80th percentile in 3 out of the 5 years from 2018 to 2022. There had at least 5% patient revenue for Medicare and commercial, and that their inpatient discharge was above the average number of inpatient discharges statewide. Go to the next slide. We see that 23 hospitals meet these criteria. If we lift the bar to being the 85th percentile in 3 out of 5 years, the number of outlier hospitals is 16. And if we use the 90th percentile, the number of outlier hospitals would be 12. So option 3 recognizes that no single measure is without limitation. This approach combines the price and relative price, the unit price and relative price measures as the basis for identifying high-cost hospitals, combining these measures along with the various criteria. Outlier for multiple years, payer mix threshold, and above the average inpatient discharges. So in this case, 12 hospitals would be considered repeat outliers under option 3 for meeting those criteria. And if we raise the bar from instead of the 80th percentile to the 85th percentile, that would yield 8 outlier hospitals. And if we use the 90th percentile, this would yield 5 hospitals. So we'll pause here and seek board input and feedback on the 3 options for identifying high-cost outliers or high-cost hospitals that may merit a sector target lower than the statewide spending target.
Open it up to the board. Dr. Pan.
Thank you so much for the presentation. Just a couple of questions in terms, the inpatient discharge threshold, which is set as the inpatient discharge threshold, thank you, which was set above the average number of inpatient discharges. So that means that automatically is it roughly 50% of the hospitals drop out because they're below average? I mean, average means, I mean, it's not median, it's average, but how many hospitals drop out because we said that you have to be above average inpatient discharges?
Yeah, I don't know that we have that number directly off at our discretion, but or at our fingertips, but I'm pretty sure we could pull it up fairly quickly and or get back to you.
Okay. So I get that. Oh. All right. Yeah. So I mean, I understand you want a certain number of discharges for data integrity, but using an average, you know, basically an average is a relative number, right? Because it's based, you know, depending on how many.
Right. Yeah. I don't know which direction the skew is, but we can.
Yeah. Okay. All right. So that'd be helpful. I mean, to me, I'd probably lean more toward picking, like, again, obviously, if the number's too high, it may not be workable. But what is the minimum number that you need to have data integrity instead of picking a relative measure like average? Because otherwise what happens is that average, well, again, it's not the same as median, but roughly probably 50% of the people drop right out right off the bat if it's below, because they'll be below average, somewhere around 50%, depending on the skew again. Okay. Then the other question the other thing I would just note is that, you know, on the different options, you know, there are some overlaps, but I also see sort of like a different combinations of hospitals. And for example, option 1, I recognize a lot of tertiary care centers. Option 2, not quite as many. There's some of them are still there. I guess I'm trying to figure out, like, inherently what is going on there. So in other words, as we're looking at these examples, is there some, is there some other adjustment that might should be considered or something or not? But I mean, I think so. I just make note of the pattern. Again, this is just from looking at that, and I know we've sort of talked about like different types of hospitals, teaching hospitals, et cetera. I'm not saying that we should carve teaching hospitals out as a separate category or something, but I do think, like, okay, what is it about those hospitals compared to hospitals in general, and whether that factor is something that we think is something that is desirable or undesirable, right? So it just would make that observation as well. And then, yeah, and then the other question I have is, I guess, so when you say 80th percentile, is, again, this is maybe it's a more statistical thing. 80th percentile, is that like drawing a line basically based, we have, if you have 100 hospitals, it's the top 20, like 80th percentile? Or are you saying like, oh, actually we applied a bell-shaped curve and said, okay, there's a standard deviation, so it's the first, right? And so I do wonder, again, this is whether we should take the approach we simply say whatever X percentage, because somebody's going to be in that percentage, right? That is there, versus let's say if they were all clustered very tightly together, which are probably not, I guess it isn't, that basically you want to really get the outliers, right? So if there's a lot of variation and it's very wide, then so anyway, just the thought about whether it should be a percentage in terms of saying, okay, you're in the top 20%, you're automatically, or do you want to say, okay, well, we took the average and we did a standard deviation, and basically if you're the upper, tier, which depending on how tightly or widely spread they are, would have different numbers of people who would be quote outliers, right? But if people are all tightly together, which I don't expect is actually happening right now, but in some senses that's what you want people to do in the end, right? You want everyone to be sort of tightly around what should be the correct cost, instead of so that you would hopefully not really truly catching the true outliers, I guess I would say, versus potentially just catching people just because they happen to be, in the top 20, the top 20%. So just another thought.
I can respond to a couple of those
Please.
questions. So just to give some context on what constitutes sort of an above average discharge threshold in a given year. So on the low end, it would be about 7,500 inpatient discharges. And then, so that would be somewhere around 2021. On the higher end, it would be around 8,300 discharges in 2019. Partly, we pivoted away from sort of licensed beds. Sorry. Thank you, Megan. So we pivoted away from licensed beds, which is invariant. And so you can have a lot of beds, but if nobody's occupying them, it's not particularly germane. And then with respect to sort of the pruning that criterion involves, so of the approximately 360 or so comparable hospitals, you do omit about 63% based on a discharge threshold above the average.
Okay, so the skew is such that you'll actually drop out 63% of all the hospitals by definition, just by doing this average.
It won't necessarily be the same hospital, so they could bounce around from one year to the next. But yes, so on average, about 63% of hospitals would be below that discharge threshold. And then just to give some color as to how that above average discharge threshold sort of translates into bed count, it would be around 378 or so licensed beds.
Okay, I guess, and I'm sure other people have comments. I mean, I understand why not bed count, but I also am a little concerned that by definition, which has nothing to do with cost, we've just dropped out 63%. So there must be some number that's like, okay, this is that the minimum discharges to allow the numbers to be stable, whatever that is, and maybe that should be the threshold.
Don, did you want to get in?
Right, just a question, a process question, really. So I know that you all have the ability to factor in extenuating circumstances when you're reviewing outliers or entities that don't meet the sector targets. Would part of this also involve a front-end review of the possibility of additional extenuating circumstances? I mean, is that built in to this part as well, or only to the back-end part?
So Dawn, is the question about setting, because they'd have to exceed the target in order for us to do the back end kind of evaluation. But yeah, if you could elaborate on kind of the front end.
Yeah, let me kind of share the thought. The thought is that so these are these handful of hospitals who are at the tippy top seemingly warrant being in a different category. But there may be among these hospitals extenuating circumstances that would say remove some of them. I guess I would be in favor of casting the slightly broader net, because this is not a very broad net. This is still a very small group of outlier hospitals, and then asking the question, are there things about some of these hospitals that should pull them off the list? And what, as a category of things, might that look like? That, it seems like potentially a more thoughtful way of honing the list.
Yeah, thank you.
Did you want to go ahead?
Oh, yeah, if the board does have thoughts on kind of what those factors might be, we'd like to hear that.
That's all I was going to say is that's exactly the point of this discussion item, is to get your feedback about, right? So the team has worked very hard to look at the data in different ways and has this merged approach. And if the board has input about what consideration should be taken to exclude hospitals, we'd like to hear that.
So I guess this is a little bit of a right back at you. I apologize ahead of time, but I certainly would be reluctant to start throwing out suggestions, because it would feel very much like shooting from the hip, and it might be helpful to have other people may be much more comfortable and know this territory better, but it might be helpful to, we've heard a lot of possibles. It might be helpful to go through them, and I think it would potentially be responsive to some of the comments that we've heard, to kind of go through them and talk about the pros and cons of adding them as considerations. So, yeah.
Rick?
Thank you. Yeah, on sort of big picture, I am attracted to option 3. Of course, I'd be interested in comments from fellow board members and the public. But the combined, the combination of the two measures makes sense to me. The commercial to Medicare ratio is capturing, as we've discussed, an estimate of how much more commercial payers are paying than Medicare, and that is, I think, an important metric to look at when we're looking at outliers, as is just the absolute level of payment, which the commercial inpatient NPR per CMAD gets to. I think that Dr. Pan makes an important point that distributions do matter, and that if all these hospitals were really tightly bunched, then taking the top 20% or top 15% probably wouldn't be a good idea. But then they're not. They're not tightly bunched. So I don't think we need to worry about that. At least we don't need to worry about it today. Maybe in 5 years, we wouldn't want the top 20% anymore, because everybody's so close to the average that, it's not a problem. But I think your first concern I share, that I think the threshold of any hospital that has discharges below the average seems to me like a pretty high threshold. And I think I had mentioned in the last meeting, maybe using sort of the 25th percentile. I don't know where that would land. And Don makes a good point that, in part the question about thresholds should be around credibility and volatility, that, really small hospitals where the data are just jumping around all the time, we don't want. But I would be surprised if, a hospital with 250 beds or even maybe 100 beds would have would have big problems with volatility and sort of credibility of the data. So I think kind of looking at lower thresholds certainly makes sense to me. But with that, that's a sort of, second comment. The first one is, I think you've done a very good job of coming up with credible metrics. And I thank you for your help in helping us think about how to make this work.
I'd want to add, we did do a cut where we removed the volume factor. And what it did do is increase the number of hospitals on the individual measure. So you'll see more on option 1, you'll see more on option 2. Andrew, I think it was like 50 or so hospitals on each list, but it didn't change the final result for option 3 in terms of are you on both and kind of the overlap.
I mean, even a stronger argument for not putting that threshold in, because then it says, well, we're looking at the universe. And even when we look at the universe, we end up with, this set of hospitals or something like it.
Ian and then Elizabeth.
Yeah, I took a slightly different takeaway from this because option 3 is the combination of the two, and the unspoken option 4 would be either or. I think as to the way we're excluding here, I'm very much on the same page about, what is the credible number of discharges or days or volume that we need to be credible. I think a 75-room hospital running 80% occupancy is going to have 22,000 patient days in a year. I don't know what that is, 5,000-6,000 discharges. That has to be credible to a degree. And then we're looking back over 5 years and taking 3 of them. We probably don't want to look at a hospital that only has 10, 15 discharges, but somewhere in there has to be a credible threshold. I do want to say I like the elegance. Dr. Kronik persuaded me earlier. I like the elegance of the commercial to Medicare payment to cost ratio or charge ratio. It does focus on the commercial. That's key, I think, and it also puts the hospitals in control of whether they are outliers, because through the rates that they are negotiating, or to the extent that they've got out-of-network care, to the rates that they're charging. So I do like the elegance of that, and I drift towards option 2 myself. On the other exclusions, we heard in public testimony and a note from the advisory committee about the psych hospitals, and that does concern me. I would not want to exclude them right now. I'd really like to learn more about what's going on there in terms of the price and margins and so forth before we exclude them. I do think there's a strong case to be made to exclude Shriners and the state hospitals. I might add to that critical access and distressed hospitals, distress fund hospitals.
Elizabeth.
Thank you. I do feel very strongly about commercial pricing being key, whichever option we go with. And I like the point that it's somewhat controllable by the hospitals. I do still hope that we will consider getting additional pricing information that is increasingly available just to inform this. Two questions, I guess. So we're talking about excluding like 340 of the 440 hospitals, basically, right? So this will be a fairly small group relative to the number of hospitals. Is that correct?
That's correct. So these would just be determined to be the high-cost hospitals, and then the others would still be subject to the statewide target.
Okay. And I did notice that it's the same 3 in all the scenarios, pretty much. Monterey, Salinas, and Stanford come up regardless of the scenario. Would anything change, do you think, if and when Kaiser data is included?
With Kaiser, at least we're aware of kind of the north and south. Kind of there may be some differences in pricing between north and south. In terms of what HCI has right now, we only have 2 years of 2 years of data that's submitted to the department so far for 21 and 22. As we get more and more data, then that could lead to more analysis, which could inform a fully integrated delivery system target that's different from the statewide target.
So a couple questions just on the methodology. Did all the hospitals pull out the same 2 years out of the 5 years analysis? Or was there variability in that?
Andrew?
So without speaking hospital by hospital, for the most part, 3 is, most of them are hitting 4 out of 5, or if not 5 out of 5 of the years. So I can provide a more detailed rundown of hospital by hospital, but for the most part, it's not, some hospitals are going to be subject to some of the challenges of the pandemic, but for the most part, it's pretty systematic. You get sort of 10 draws, right? 5 years plus 2 different metrics, and they're exceeding those percentile thresholds pretty consistently across those 10 opportunities.
Great. And then I'm curious, the recommendation around excluding psychiatric hospitals was why?
Oh, so there wasn't a recommendation to exclude them. We presented data analysis, both the advisory committee and today, kind of 2 lists, one with exclusions and one without exclusions. So I think the advisory committee members were reacting to seeing psych hospitals on the first list without exclusions, in terms of the high operating margins that some of them were generating.
Yeah, I mean,
But they are excluded in the options that we presented here
Yeah.
by virtue of the data that are reported to HK.
or just by
Oh,
data,
yeah,
not
sorry.
by analysis, not by methodology.
Yeah. In terms of the law, they're a hospital, so they're subject to the target. But yeah, for the data analysis, they were excluded.
I mean, I do note that there are a number of hospitals that, regardless of what methodology, are in the super high list. And I'm a little inclined towards option 3. I think that there's probably, to Don's point, some of these outliers for which you'll want to understand why and consider what the target should be for them. But as a methodological approach, I'm sort of struck that the list of what you get in option 3 seems to me to be hospitals in a lot of different regions. Worth us looking. Anything else from the board?
We'll now move to public comment on.
Dr. Pan, you have something?
I just appreciate discussion. Certainly looking forward to hearing public comment. I think probably for our first approach, I would also lean toward option 3 because I think we need to create that confidence that we're hitting the right target. I think there's still a lot of work to do on the methodology, as we've talked about before. So as we work through that, hopefully we can see whether we make some adjustments as a result of that. But for now, option 3 does seem like it's probably the best initial approach.
All right, we'll now take public comment on this item, alternating between those in the room and those attending virtually, starting with virtual. Susan, go ahead.
Afternoon, can you hear me?
We can. We're going to adjust the volume.
Okay. Good afternoon to the OCA board. My name is Susan Green, the CFO for Sharp Healthcare. Sharp Healthcare is deeply concerned by the speed with which OCA is proposing methodologies to identify disproportionately high-cost hospitals and establish sector targets for these facilities. We urge the OCA board to direct staff to undertake public workshops to engage with stakeholders on proposed methodologies for identifying high-cost hospitals. We want to engage with OCA staff to find a fair and equitable methodology that will result in lowering cost trends. Sharp was surprised to see Sharp Chula Vista Medical Center listed as a potentially disproportionately high-cost hospital under option 2. Sharp Chula Vista Medical Center is a disproportionate share hospital as determined by CMS, with nearly 80% of patients covered by governmental insurance, and includes a significant amount of fully capitated revenue for commercial and Medicare Advantage. Looking at the HCI hospital financial reports used by OCA, Sharp Chula Vista had an operating loss of $40 million, or a negative 7.6% operating margin in fiscal year 22. And for the 5 years from 2018 to 2022, Sharp Chula Vista recorded a loss of $111 million. It is also important to note that Sharp Chula Vista operates the only labor and delivery unit in the South County of San Diego. And Sharp Chula Vista is only one of 2 hospitals that receive ambulance transports for patient emergencies at the border. A reduction in spending targets to Sharp Chula Vista would severely impact our ability to serve and care for the growing and vulnerable community. From what we can glean from the very quick analysis is that OCA is using gross charges divided by payer to estimate cost by payer without the benefit of understanding the actual cost to provide care and the mix of capitation and fee-for-service revenue. Methodology matters, as evidenced by the potential for Sharp Chula Vista to be considered a high-cost hospital when its proportion of commercial insurance would never drive overall cost trends. On behalf of Sharp Healthcare and the communities we proudly serve, we urge the board to direct OCA staff to meaningfully and transparently engage with stakeholders to identify data-informed methodologies. OCA has a responsibility to transform healthcare in California. It must be done in a manner that not only promotes affordability, but maintains access, quality, and equity. Thank you.
Going to the podium, go ahead.
Beth Capel for Health Access California. As this board has repeatedly discussed, cost structures did not come down on stone tablets and are subject to correction and improvement. We like the combination, as others do, of the 2 measures and the notion of repeat outliers, which we think also helps to address the COVID year, which we also are mindful of. Again, we oppose delay. We support moving forward. We do think that the board discussion about a more appropriate threshold for including hospitals in the analysis of high-cost hospitals is worthy of consideration. By our estimation, more than 300 of the 440 hospitals have been excluded from the analysis of high-cost hospitals. This again disproportionately affects the small hospitals in the LA Basin and elsewhere in California that developed after World War II. We don't think that's the intent of staff, but we think that's the effect of this methodology. We would also note, building on the earlier discussion, that one of these measures, the comparison to Medicare, includes both inpatient and outpatient, which is to us very important as well, and we appreciate the board discussion. And for those who encourage more public discussion, we'd encourage them to show up and participate. Thank you.
Looking back virtually, Travis, go ahead.
Hi, good afternoon, everyone. Travis West, Regulatory Policy Specialist with California Nurses Association. While we support the project of identifying hospitals with disproportionately high spending, we must ensure that imposing lower spending targets on such facilities does not result in adverse consequences for healthcare workers and patients. It is essential to develop an understanding of why spending at such facilities is disproportionately high, and to know what is going into operating expenses to be able to determine if lowering those expenses is appropriate. Some spending, such as spending on workforce development programs, increased wages, or increased staffing, might have large upfront costs but result in lower costs and better health outcomes in the long run. Ending such workforce investments or closing high costs but critically important services like trauma centers and maternity units in the interest of lowering costs to meet a spending target may have the perverse effect of actually increasing overall spending if quality of care declines or if services are cut, making healthcare less affordable for patients in the long run. OCA must also ensure that facilities facilities are not cutting costs off the backs of workers or patients, such as reducing staff, lowering wages, or cutting services. For these reasons, CNA strongly encourages OCA to consider targets for individual hospitals in the sector evaluated on a case-by-case basis rather than for a group of hospitals or all hospitals in the sector. CNA also encourages OCA to continue its work in developing, refining, and ultimately implementing clear and enforceable workforce stability standards to help address these issues. Thank you so much.
Thank you. To the podium.
Ben Johnson from the California Hospital Association. OCA's options for identifying high-cost hospitals are overly contrived, featuring exclusions of hundreds of hospitals, really 300, more than 300 of the 400 hospitals operating in the state. Moreover, it doesn't even look in these exclusions at financial performance and is often based on dubious distinctions in terms of how care is delivered and the underlying performances of the hospitals themselves. The latest iteration excludes dozens more than the original set reviewed last month and diverges from its prior approach of using multi-year averages and instead using multi-year counts, all without explanation. Of the hospitals listed under these options as being high cost, 13 had negative operating margins on average over the five-year time period under review, one having a negative 29% average operating margin, and it's unclear how this hospital would survive under the target values being considered. What's more, the office's approach, it relies on a 5-year data period featuring the worst pandemic in a century, which created shocks and distortions in hospitals' finances in 3 out of the 5 years proposed to be used for prospective sector target setting. These associated data issues must be addressed before proceeding in this manner. Thank you.
Thank you. Virtual, Kevin, go ahead. Kevin Causey, you're unmuted on our end. You might need to unmute on yours. Go ahead.
Can you hear me now?
We can, yep.
Oh, perfect. Thank you. Thank you for your patience. And thank you, Chair and Board. I'm Kevin Causey, Chief Development Officer for Montage Health, and I'm representing the Community Hospital of the Monterey Peninsula. And as we sit here again through today, we remain profoundly alarmed by the processes and actions taken under the aegis of the Board. And from its inception, there's been a small yet vocal group of organized labor representatives who have seized control of the agenda, pushing a specific, false, and harmful rhetoric to unfairly malign people trying to give care in the best way and in the most efficient and cost-effective way we can in Monterey County. Month after month, representatives of Salinas Valley Federation of Teachers unite here, malign, misrepresent the cost and pricing challenges faced by our hospitals here, serving their communities throughout the county. They use incomplete, cherry-picked data, isolated, dubious anecdotes and innuendo, and have created a false narrative that Monterey hospitals, specifically CHOP Community Hospital, are the most expensive in California. And we spent the whole morning looking at data to prove that your data to prove that that's just simply not the case. And last month, McSig's leadership, with whom we have been in negotiation for 18 months and have put offers on the table to them that would have lowered their healthcare costs by significant 7 figures, and they can just do not accept nor even counter offer, and yet blame us for the high cost of healthcare to justify a $6.7 million assessment to their membership. You know, saying that they should pass those costs along to their employees or take it away from the students of Monterey County. When we have to ask, where's their management of their drug utilization? Where's their stop-loss strategy? These are the things that they should be focused on. And the other thing is that there's not any recompense or even acknowledgement for the hospitals like ours who are taking steps to do everything we can to lower costs. We're in the middle of a $50 million cost reduction process right now. We set up a $5 billion fund for teachers in the community to at least soften the blow a little bit while we continue negotiations with their union representatives. So we can't help but think that this is, political theater generated by them. And we ask that you see through all of that and really engage with us. These actions, this situation just has no precedent. There are no statutes that govern it or define these steps and how you're looking at these costs. Again, it's been discussed, system costs versus hospital costs and all the care that we provide to the community. And we're confident that if we continue to get singled out unfairly, this is not going to withstand legal challenge as we move forward. Thank you for your time.
Thank you. Looking back to the, go ahead at the podium.
Good afternoon, Joan Allen, SEIU United Healthcare Workers, and want to really thank the staff for all of the incredible, thoughtful work that has gone into this proposal. This is a huge task, and I know that California is building on years of work from other states that have used some of these metrics and have wrestled with these, but California is such a big and unique place that we will always go further and go bigger on behalf of patients and workers and consumers. And so appreciate what we're doing here and appreciate the action to define hospitals and to really tackle this as the first sector that we're looking at. Feel like the options presented get to a reasonable set of hospitals. Option 3 gets to a reasonable set of hospitals, but would encourage staff to continue looking at different ways to make that data more rock solid. I'm a little concerned about using the mean discharges, honestly. That does feel like it is taking such a large number of hospitals out, and would wonder if there are ways to get at that same concern about volatility within the data by looking at categorical considerations, particularly critical access hospitals and hospitals that have received distressed hospital loan fund disbursements, and then taking another look at that, at whether that mean can be brought down so that we're not excluding so many hospitals based on that discharge standard. But feel like this is going in an incredibly positive direction for consumers and patients throughout California, and appreciate seeing the final product that comes back to this board. Thank you.
Thank you. Looking back virtually, Katie, go ahead. Katie, you're unmuted on our end. You might need to unmute on yours.
There we go. Good afternoon, board. Katie Bassler, President of Salinas Valley Federation of Teachers. I didn't make the long drive up there today, too much work here, but wanted to take a moment to appreciate, as others have said, the work of the board, the consideration of the workers of Monterey County. And this will be short because I want to simply express that these are positive steps for accessibility, affordability for the workers of Monterey County, which include hospital workers, service workers, and educators. I look forward to the next steps. And today was a huge step for all of us to feel some relief through the work of the board. Thank you very much.
Thank you. Looking back to the podium, seeing no one, looking virtually, seeing no hands raised, noting for the record, we have about 103 virtual attendees. That concludes public comment on this item.
All right, so we'll continue with options for setting sector target values. And again, this is a discussion where we'll be soliciting the board's feedback and input in just a few slides time. So if we go to the next slide. Try to give a truncated overview of the statute, as I think you've heard me read most of this here today. But the most pertinent pieces of it. The board shall establish specific targets by healthcare sector, including FIDs and geography and individual healthcare entities as appropriate. The board may adjust cost targets by healthcare sector, including FIDs, geography, and individual healthcare entities when warranted to account for the baseline costs in comparison to other healthcare entities in the healthcare sector and region. And the setting of different targets by healthcare sector shall be informed by historical cost data and other relevant supplemental data, such as financial data on healthcare entities submitted to state agencies and the healthcare payments data program, as well as consideration of access quality, equity, and the healthcare workforce stability and quality jobs. So after hospitals are defined as a sector, the board can set or adjust targets as follows. Targets could be set for individual hospitals within the sector, targets for a group of hospitals in the sector, and or one target for all hospitals in the sector. In the following slides, the office presents a formula-based approach for adjusting the statewide spending target for a group of high-cost hospitals. This approach would be transparent and easily understandable for the public and regulated entities. The next slide. So here we present a formula-based approach. The target value for high-cost hospitals could be based on the statewide spending target and adjusted according to the average cost relativity of the included hospitals. I'll define cost relativity. The hospitals could be assigned a cost relativity tied to the California statewide mean for commercial inpatient NPR per CMAD or another measure, but we just use this as an example. So in this example, the statewide spending target for 2025 is 3.5%. And if a hospital is on average twice the statewide median on commercial inpatient net patient revenue per CMAD, they would be assigned a cost relativity of 2. And then the hospital's target would be adjusted as such. So you would take the statewide spending target of 3.5% and simply divide by 2, and you'd have a resulting target of 1.75%. If we go to the next slide. So some considerations for this approach. The target values are directly related to hospitals' costs. The methodology for setting the high-cost hospital target is transparent, and this method could be adjusted on a facility-by-facility basis. So you could create a different target value for each individual hospital. This would increase administrative burden and complexity for the industry to track and implement the specific target values. And different values may result in challenges for communicating the policy to the public. So drawing on so if we go to the next, you're already on the next slide. So drawing on the examples that we discussed in the prior section. So suppose the board agreed that the 5 highest cost hospitals on the combined metrics merited a lower cost target. So those above the 90th percentile on the unit and relative price metric. For 2018 to 2022, their average inpatient NPR was 42,835 compared to 20,418 for all other comparable hospitals. So this would give you a cost relativity of 2.1. 3.5% divided by 2.1 would yield a target value of 1.7%. And so the spending target could be, in this example, could be 1.7%. Another example, suppose that the board agreed that the 12 high-cost hospitals, i.e. those above the 80th percentile, merited a lower target value. The price relativity would be 1.8, and the resulting target value would be 1.9. Going on to the next slide. Does the board have input on how to set target values for the disproportionately high-cost hospitals? And does the board have input on how many years this sector target ought to be set for? And noting that targets can be revisited after they are set and be modified by the board.
Board members, anybody have comments? Dr. Pan, do you want to get it? Yeah.
Thanks. I see the attraction of doing the in proportion to the sector-wide target, which is right now the same as the statewide target. It would eventually bring those outliers down closer to the norm, but at least by the back of my envelope, it wouldn't do so. It wouldn't bring them below where the 80th percentile is right now until 2065. And that doesn't seem aggressive enough to me. So I don't know if it's it's as simple as a 0.1, but that would be more aggressive. So that's my main comment. Obviously, I do think we need to address all of these, so the 80th percentile and up.
Dr. Pan.
Thank you. Even though we did get slides in advance, I think I need a little more time to think about this. But I do appreciate that the staff is pursuing a approach that would be transparent, easily understandable. I think it's important that people know what's expected and that it's and that we're developing standards and we're not like pointing at particular hospitals that you and you and you just because that it's based on we've come up with standards and formulas and we have a methodology. I think the methodology is important and that people have confidence in that methodology, that it's fair. They may not like it, but at least they view it as fair and reasonable. And so I appreciate the staff's approach. One of the questions I have in terms of the cost target itself, frankly, this was actually raised in the advisory committee, not on this particular issue, but so for example, Zuckerberg General Hospital, I guess the San Francisco General Hospital, which was actually on the list for option 1. They don't take a lot of commercial patients, I was told, and maybe if I'm wrong, and so yes, their commercial is very high, but it's a small percentage. So I guess the question is the cost target, and I don't know what percentage of commercial, but if it's a small percentage, does that apply for the hospital across the board? If let's say it's 5 or 10% is commercial, but the cost target that whatever it comes out to be, turns out to be 1%, let's just say, does that apply for their entire book of business? But it's driven by them being flagged as, their commercial is being a small fraction of their total book of business. So I just want to know how this cost target applies, since it's so focused on commercial, but if commercial is not a large portion. So, a lot of public, there may be public hospitals where basically they're mainly Medicare, Medicaid, or Medi-Cal, right? And so are we applying a cost target based on the commercial, even if their commercial is a small percentage? And how does that affect the fact that, basically, depending on what Medicare and Medi-Cal allows them to do, are we going to tell them, like, actually, you can't partake of that because these are on the commercial side?
I think that's a decision point. With the statewide target, we're going to look at it by market. And we had previously discussed kind of, there are some considerations for Medi-Cal that, some state and federal decisions that affect spending patterns and trends. So for this one, if it could be, it could just be one target, but then we're just going to have that special consideration for the other markets. And then we could kind of return to the board next month and kind of with kind of more context on whether it, it could be a commercial only target. But at least just off the top of my head, I think you could do it by market.
Okay, well, appreciate you thinking that one of the questions put out there come back. You can come back to us in your thoughts, and maybe as Stuan as well may have some suggestions too. Thank you.
Rick?
Thank you. The cost relativity approach has a nice kind of symmetry to it. I mean, if these hospitals are twice something, then their target should be half of the regular target. It does raise, it's a nice symmetry, although I'm not sure I think we might need to come up with I'm not sure I can articulate the full logic behind it other than the symmetry. If we are going to go that direction, be good to get some consideration of if we do go in the direction of option 3 and use 2 metrics to get into the high cost pocket, then should we be looking at cost relativity for an average of those 2 metrics? I mean, the example you gave was one of the metrics. I know it was just an example, but that at least is a question to think about. I do think that where Ian was starting is in principle maybe a more defensible place to start, which is, while we're concerned about these high cost outliers, we are establishing, if we go in this direction, separate targets for them. And the purpose of that is so that they are no longer high cost outliers. And so at least, if we do go in the cost relativity direction, at least being aware of how many years will it take for them not to be high cost outliers. Ian suggested 65 with his envelope, but be happy for you to actually come back with an estimate there. But also think about whether an approach to establishing the target should be that in some number of years. I don't know whether that should be 5 years or 10 years or, Elizabeth will say 2 years. The target should be set at a level so that these hospitals are no longer high cost outliers. And whether that should be the approach or just something that we're paying attention to as an outcome of some other method, we should be paying attention to that, I think.
Elizabeth?
I have a question. So let's say we do this approach and give them a time limit, but how does this specific target for the high cost outliers impact our calculation of the overall target? Wouldn't that make it a lot easier for the other facilities to stay within the limit, the 3%, 3.5% limit, if there's a little extra? No, I'm just wondering if
the cost targets the cost targets applied to each healthcare entity individually.
Individually.
Yes.
Okay. Thank you.
One impact. Secretary, do you want to get it? I sort of have a process suggestion, given all the feedback we've gotten around methodology, and that would be to get with 1 or 2 of these high-cost hospitals that sit on both of these lists, regardless of methodology, and actually look at what the circumstances are, so we as a board have some sense of what those variables are, so that if, they're a disproportionate share hospital and they only take commercial for trauma and we would want to know that. And I think it would give us a better insight into understanding how to use the methodology to get where we're trying to get, which is lowering costs sooner rather than later, but making sure we maintain access. And so I think and I'm not proposing we do this with our affiliates, but with specific hospitals, and sit down and sort of say, okay, how is it that it works out this way? That addresses both the process feedback we've been getting, and I think we'd learn a lot. Anybody else comment on this? The board? Do we need to take public comment? Public comment. Oh,
So sort of go, so basically you've heard from us when we hear from the public, and then you're going to come back and get some more. Yeah. Okay. Will we be taking action next month?
The office does have a March 1st deadline to propose a target setting methodology and target values. So
Okay.
similar to last year, we would
Okay.
put out a recommendation for you all to discuss, and then,
Okay.
the same timeline until June for adoption.
Okay. All right. So we'll have time at the next meeting to work on this some more, and hopefully we've gotten more input from a variety of people. I think the challenge is give us some options or alternatives. If you don't like it, tell us what you'd like us to do instead. Okay. Thank you.
Okay, let's take public comment.
We'll now take public comment on this agenda item. If you're attending virtually, please raise your hand. In person, step to the podium, going to the podium first.
Beth Capel for Health Access California. The discussion of the board has been very helpful. I would say that the reason high cost outliers are in the law is both a recognition of the impact that they have on premium costs, and that we do want to get to a place where, to use statistical terminology, the dispersion is less. We are where high cost outliers are moving closer to the average. I will also note that the average has crept up in the years that we've been working on this. There are states that are now looking at 160% of Medicare for reference pricing. I think I hear a lot of discussion in California about 200% of Medicare. Even that is now below the average. And so when we look at these hospitals that remain on option 3 for the one that the board preferred and we prefer, we're talking about hospitals that are above 300% of Medicare, and in some cases above 400% of Medicare. And that's worth keeping in mind as you think about how you're going to set a lower cost target. I would also say if you're down to 10 or 12 or 15 hospitals that are your ultimate list, probably one target is enough for that many hospitals in terms of just managing the work of the staff and the work that the hospitals will face. I did want to give credit. A number of the hospitals who wrote in had sort of high-level overview of how they're trying to meet the 3.5% target. And as we have said repeatedly, those people who are trying to get to the right place of lowering costs while protecting access and improving quality, we're willing to work with. It's the people who don't seem to even care about the damage they're causing to consumers for whom we have no patience. So we want to thank you. This is the only forum that exists in which consumers and other purchasers can explain the damage that is being caused by the very high cost of healthcare. So we appreciate the work of this board and the staff to listen to these discussions. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Ben Johnson, California Hospital Association. We are extremely concerned with potential adoption of lower spending targets for some portion, at least, of the hospital sector. As with the statewide target, OCA's methodology for setting any sector target must have sound foundation. Fortunately, with the formulas reviewed so far, they appear to confuse hospitals within year performance on a given measure with year-to-year change in performance on the same or a similar measure. More problematically, the values themselves are 35% lower than statewide inflation for all goods and services is projected to be by the Department of Finance in 2026 and beyond. And OCA has not offered any analysis to date on potential downstream effects from these or lower targets, including on access, quality, and equity. Already today with the statewide target and pressures we know that were intended with the statewide target, they are hampering continuity of care and the ability of hospitals to remain financially stable at the terms that are offered by plans. And a lower target on some hospitals would only exacerbate these challenges. OCA has previously suggested that the selective enforcement, I think this was just implied as well, can be used to avoid negative impacts, but this is a risky presumption given that patients are in the crosshairs and they could lose their usual sources of care. Pushing below, or lastly, just want to note that this discussion is occurring in parallel with more than a dozen federal proposals currently under consideration to radically defund California's healthcare system by tens of billions of dollars, which would decimate healthcare coverage in the state, cause untold hospital closure and service reductions, and endanger the health and lives of California's residents. OCA risks exacerbating these challenges and must consider the broader political context in these decisions going forward. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the room, seeing no one at the podium. That concludes public comment on this item.
Okay, thank you for that. Let's move on to item C, I believe. CJ? That you? Shaw?
So this item's going to be presented by Margareta and CJ, Andrew, and I will support if needed.
Good afternoon, members of the board. Margaret Brandt, Assistant Deputy Director for Health System Performance at OCA. So in the next two slides, I'll recap our approach to collecting alternative payment model data and primary care spending data, which is now included in the THC Data Submission Guide version 2.0 that has been released for public comment. And then I'll turn it over to Andrew to review key dates in our timeline. So we could go, or we're on the next slide. So as we've discussed previously, OCA is proposing to collect alternative payment model data using the expanded framework, which is HCI's detailed non-claims data collection framework. And the expanded framework categories crosswalk to the HCP land categories for alternative payment models, and the alternative payment models that count towards OCA's APM adoption goals are defined by HCP land category 3 and 4. So OCA is proposing to collect APM data using the following approach. So we're collecting payment data for APM arrangements linked to quality and those not linked to quality separately at the market category and product type level, since payments must be linked to quality to count towards the adoption goals. We're collecting APM membership data by market category and product type at the payer level, since the APM adoption goals are tracked by the percent of members attributed to HCP land category 3 and 4 payment arrangements. And then we're collecting APM spending data as a per member per month and as percent of total medical expense at the expanded framework subcategory level. So total medical expense and member months for members must be reported in the payment subcategory furthest along the continuum of provider clinical and financial risk. So here, for example, if a health plan pays for a care management fee on behalf of a member who is also in a professional capitation arrangement, then all claims and non-claims payments and member cost share will be reported in the row for the professional capitation arrangement. And this data collection approach is consistent with how HCP land collects APM adoption data, which allows OCA to compare California performance to national APM adoption levels. So now we'll turn to a recap of our primary care spending data collection approach. So here, as a reminder, OCA proposes to collect claims and non-claims primary care spending data by market category and product type at the payer level to track progress towards the annual improvement benchmark and the 2034 primary care investment benchmark. Claims and non-claims primary care spending will be collected based on the methodology developed by OCA with input from the Investment and Payment Work Group and many others. For claims-based primary care spending, the primary care code set defines the provider taxonomies, the places of service, the services that must be present on a claim for inclusion in primary care spending. For non-claims primary care spending, data submitters must follow the methodology for allocating a portion of non-claims payments to primary care for each expanded framework subcategory. So for example, data submitters will follow the methodology for how to allocate a portion of professional capitation to primary care. Additionally, spending for behavioral health care provided in a primary care setting will be collected as part of primary care spending. So there's a subset of a few behavioral health services that are provided in a primary care setting that will be collected, also non-claim, anything related to non-claims for behavioral health in a primary care setting. So now I'll turn it over to Andrew to walk through our timeline for the data submission guide, public comment, and 2025 data collection.
Thanks, Margareta. So yep, just brief timeline overview for 2025 data collection. We're excited that draft updates to the regulations and our data submission guide 2.0 were released earlier this month for public comment. The public comment window does close at the end of this month, so we've certainly benefited tremendously from the feedback from submitters this past year, and so we continue to expect to receive thoughtful commentary in the days ahead. But we would ask that any comments be shared on or before the end of this month. And then OCA expects later in the spring, around that April time period, to submit those updated regulations and the Data Submission Guide 2.0 to the Office of Administrative Law. And we have hyperlinked here those draft regulations and Data Submission Guide 2.0 for anyone interested in reviewing said documents. We can go on to the next slide. So this is an overview of our data collection timeline beyond April, and this is going to be very similar to what our process was in 2024. So in that May timeline, required submitters are going to be expected to complete registration through OnPoint's Claims Data Manager. The following month in June, required submitters do have the option to submit test files. This is just an opportunity to work through any connectivity frictions that may emerge. And then in the months of July and August, submitters have an opportunity to prepare their data files for calendar years 2023. During that time, as was the case this past summer, OCA does intend to meet with data submitters to answer any questions they may have, as well as to provide technical assistance if needed. And required submitters are then expected to complete their data submission on or before that September 1st, 2025 deadline. Towards the end of the year, OCA will once again meet with required submitters, or any data submitters for that matter, to review their data and to preview what they can expect to see in the second baseline report. And then finally, OCA's second baseline report would be published on or before June 1st of 2026. And when we shared this content with the advisory committee last week, there were no substantive comments on these items.
Questions or comments? Dr. Pan, you want anything?
Yeah, I would agree that the presentation was well made and the advisory committee did not have any significant comments. So good job on staff.
Anything else from the board? Elizabeth?
Sorry, another question. Will we be seeing the quality metrics that are being used? Because I think rightly, all the APMs are connected to quality metrics. Do we know what those are?
Marguerite, you hear that?
So if I heard the question is, will we be collecting information on the quality metrics that are associated with the alternative payment model arrangements?
And will the board see those?
So no, we are not collecting data from each payer on the specific quality metrics that they use for each of their alternative payment model arrangements. We're asking in our data submission guide, we're asking, are these payments linked to quality or not? And they will be reported separately if they're not linked to quality compared to if they are linked to quality.
Does OCA have a list of approved quality metrics?
We do have a list of recommended quality metrics in our alternative payment model standards, yes.
So if they say yes or no, it will be sort of against that list?
We are not specifically saying you must use these, those quality metrics. So I think that would be a consideration for future data collection if we wanted to specifically ask about the quality metrics that we've listed in the alternative payment model standards.
That would be important.
Anything else from the board? Thank you, Marguerite. Appreciate that. Let's take public comment.
We'll now take public comment on this item. Please step to the podium. Looking virtually, seeing no hands raised. Seeing no one at the podium on this item, that concludes public comment.
Good afternoon, board members. Sheila Chatayan, Assistant Deputy Director for the Compliance Branch of OCA. It's good to see you again and Happy New Year. I want to introduce a member of my team, a very important member, our Assistant Chief Counsel, Heather Klein-Hoganson, who will be making the presentation today to update you on our CMIR program. Heather gave the presentation at the advisory committee meeting, and so it's a great opportunity to be consistent and have her present the update to you.
Thank you. Welcome.
Good afternoon, members of the board, staff, those who are listening virtually. As Sheila mentioned, my name is Heather Klein-Hoganson. I use she, her pronouns, and I am one of 2 assistant chief counsels in the compliance branch at OCA. We could go to the next slide. You may remember this slide from October. This is an update of our October presentation. For those watching who are unfamiliar, these are the factors that OCA will use in determining whether a transaction that is submitted to us as a material change transaction, such as a merger or acquisition, needs to have a cost and market impact review, which we call CMIR. I won't read the factors to you. They are here on the slide, but they do involve looking at negative impacts and competition effects. So since our last report in October, we've had 7 complete submissions, and I'll share those with you on the next 4 slides. And we have completed 10 in 2024, which is only April to December, since we did not begin collecting notices until April per statute. As a comparison, Oregon has recently published a report of the transactions they have looked at, and nationwide, they felt that there were 58 transactions. And so for California to have 10 indicates the size of our state. Of the 10 complete transactions we've had for review, 1 was submitted and then withdrawn after discussions that they did not actually meet the regulatory requirements to file. We've had 16 separate complete submissions, so many transactions have more than 1 party or subject of that transaction, and individually they may or may not have to file. So out of 10 transactions, we've had 16 complete submissions that OCA staff has reviewed. Of those, 8 waivers were issued by OCA, and the average time to review before those waivers were issued were 22 working days. And I mention that because I know that as we were developing this program, there was a large concern about how long this would take and was this going to delay, implementation of contracts. So although we have 45 days to tell parties or subjects of a transaction that they will have to go to a cost and market impact review, we have been under that deadline thus far. And of those 10 that were submitted from April 1 to December 31st, 2 are still in review. Right now, we are working on 7 submissions. We've had a number of transactions already submitted in January. And we do list all of the submissions of transactions once they have been deemed complete on our website. And for those interested, the link is there. And that is updated as soon as we can when we do declare that a submission is complete or when we waive a CMIR or determine that it will go to CMIR. So on the next slide, those transactions in reverse chronological order from the last update to you, Agile and Acaso, those are occupational healthcare, like workers' comp sort of things. That submission was just declared complete on Friday, so we were able to get that into the board slides. That really is a merger of Northern California and Southern California occupational healthcare groups. Sharon Care LLC, the next one, is an 86-bed skilled nursing facility in LA County, and it is being sold from Summit Care to BQ Operations, and Bold Quail is that entity. On the next slide, you'll see another skilled nursing facility, Alta Care Gardens Care Center, is also being sold from Summit to Bold Quail. Alta is in Orange County. It's a skilled nursing facility of 129 beds. Then we have the Korean American Medical Group and Swan Practice Holdings. That's independent practice groups that affecting Los Angeles, Orange, and Santa Clara counties. And we just waived this one recently. The next slide. CSI Medical Group impacts dermatology practices, statewide, plastic surgery. And that one's still in review. And then Ambry Genetics Corporation and Tempus AI is risk screening labs for cancer and genetic factors. That one is also still in review. And then finally, the next slide, KTLA Properties. That is in Anaheim, Orange County, the Alamitos West Health and Rehabilitation and Catella Senior Living Community. That's a 142-bed skilled nursing facility in Orange County. And that was also waived recently. So that's kind of the overview of the types of transactions we've been looking at recently. We also, both by regulation and practice, invite members of the public or law firms or those involved in transactions to send us questions through our CMIR inbox. Just a regular email, cmir@hchi.ca.gov, and people can send us questions about, hey, have you heard about this transaction? Or I'm thinking I may need to file. Our top questions really are, do I need to file? Here's a fact situation. And often that ends up saying, yeah, we may need to meet and discuss this further. And so we've had a number of meetings based on those emails. We also have questions about confidentiality. And then finally, as I mentioned, hey, there's these deals. Are you guys looking into it? Our goal is always to respond to questions within 2 business days. And we, of course, do not provide legal advice, but we are available to clarify points or point to other resources. And while the office will not be reporting on potential deals for a variety of reasons, including that the deals may be being reviewed by other state agencies, such as the Attorney General's Office or Department of Managed Healthcare. Maybe they're not ready to be reviewed by anyone yet. They're still negotiating definitive terms. But we have been working with our sibling departments and other HCI offices to determine if certain activities warrant filing with us. And we have reached out to certain parties involved in transactions to find out, what their status is and are they going to be filing with OCA. As the slide shows, we've had a number of those emails. Since October, we've had almost 40, and that's resulted in 10 meetings. For 2024, we've had at least 117 questions and 23 meetings. And there's probably one or two more that were follow-ups that required a couple of meetings. So the number of actual meetings is more than that, but the parties involved is at least 23. And with that, if there are no questions, I'm
Thank
ready
you, Heather,
to.
for that report. Dr. Pan?
Thanks so much for that presentation. First of all, really appreciate the fact that you're getting these waivers an average of 22 working days. I know one of the concerns was how backed up. I don't know if you can, a couple of questions, whether you can comment on, at least to date, when you do have to do a review, how long that takes, right? And then I guess the second question is that in a state as large as ours, I realize this is not been that long, but it didn't look like any of what was filed involved private equity. But are there private equity transactions that have come across the office at all? Doesn't appear to be, but I don't know the entities well enough. So
To your first point, in terms of the length of time for review, those 22 working days have been ones that we
For
have
review.
waived a CMIR.
Right,
We have
yeah.
not sent anything to a CMIR at this point.
Okay.
We anticipate that will eventually happen, but as we presented when we were developing our regulations, that will most likely be a small percentage based on what we've seen nationwide for those states that engage in this practice. In terms of private equity, there have been a couple of the transactions that we have reviewed that did seem to have some financing in private equity issues. If you remember from last report, there was a joint venture between Elevance and Clayton Dublier and Rice. I hope I just pronounced that correctly. That involved some private equity. And I believe the CSI medical, the dermatology plastic surgery one, there is some investment opportunities on both the current operator and the proposed merger.
Okay, thank you.
Other questions from the board? Rick?
Thank you, Heather, for that, very helpful report. I remain surprised at the relatively small volume, although I noticed, a large share of the 58 that were flagged by someone. I wonder about, I know that close to home, Brady Children's Hospital is merged with Children's Hospital of Orange County. I think they announced that in December of 23, so maybe that was somehow before the regulation went into effect, although it didn't happen until well after. Was that filed with the office?
So 2 points there. One, if it's a nonprofit entity, that deal may be reviewed by the Office of the Attorney General and would be exempt from coming to OCA. And second, to your point about the numbers, if you remember, we did revise our regulations in August, and the number of deals that are now captured is greater than it was from April to August. So we are getting a few more transactions being submitted to us because they are now being captured when before they were not.
Thank you. And just to make sure I understand, so the transaction between two nonprofits that would be reviewed by the Attorney General does not need to be filed with OCA.
It's governed by the acquiring entity. So if the acquiring entity is a nonprofit, it's under the AG's jurisdiction. And then as far as Oregon, takes a broader scope because they, as far as I know, in California, we have the Attorney General, we have the Department of Managed Healthcare, we have the Department of Insurance, all looking at transaction activity, not the same in Oregon. So Oregon looks at vision transactions, they've looked at some large vision, some dental transactions, and we do not look at those. So there's that accounts for some of the difference in them, in the numbers. So.
And also that 54 number, that's what Oregon reported was being seen nationally. Of that number, they were reviewing 24. So not all 58 was being reviewed by Oregon. That was just their look at the national.
If I could just follow, the poster child that I think of in this area is the story about MGH and a hospital on the South Shore, whose name I forget, in Massachusetts, where the Health Policy Commission in Massachusetts reviewed it and provided a report, which I then think eventually the Attorney General in Massachusetts said, we're not approving this transaction based in part on what the HBC had said. So I belatedly understanding that our model is quite different. Is that right?
Correct. Yeah, OCA's scope and jurisdiction does not include approving any transactions. And if there were transactions that we felt would negatively impact access or competition after a CMIR was done, statutorily, we can refer that to the Attorney General and they can take action if necessary.
Right, I understand that. And in Massachusetts, the Health Policy Commission also doesn't have the authority to approve transactions. But at least in that example, which is, held up often as kind of the big thing that the HBC did, the transaction did come to them for review, even though, but it sounds like in California that transaction, a similar transaction would not come to OCA for review.
Correct. Certain transactions go to Department of Managed Healthcare, certain transactions go to Department of Insurance, and certain transactions go to the Attorney General. Those are exempt from our review unless one of those sibling departments refers it to us.
Thank you.
I believe you're thinking of Steward hospitals. Is that what you're thinking of? In Massachusetts? Yeah, and recently that they've changed their legislation as a result of a lot of the difficulties and challenges they're facing there. So it depends on the status of the entity. A hospital is a healthcare entity, so they would be required to file with us unless they are nonprofit. So when you asked if the Steward transaction, like a Steward transaction would come to OCA, it's a possibility.
Dr. Pan?
Yeah, given the various number of entities you talked about who might end up reviewing, is there any conversation happening with some of those other departments about compiling perhaps a more complete report of what's going on in California? The AG's office got this, we got that, DMHC got this, et cetera.
We are in contact with our sibling departments on a frequent basis, yes.
Okay, but I mean, is there a plan to maybe compile a report that comes from all departments saying this is what's happening in California, and perhaps something you might be able to share with us or other interested parties?
For transactions that have not come to us or that we hear about, that we aren't really in a position to, discuss them publicly, but our mission is transparency. And so we have been exploring the idea of the first step would be to put on our website the links to DMHC and to the AG's office so the public can easily reference the transactions that they're looking at because they post them as well on their website. And then, as you know, we have the statutory authority to conduct studies. And so, my hope as we get more transactions and our program develops is that we can do some compilation and some public studies, even simple ones. So.
Just to add to that, Dr. Pan, we ourselves may not the departments themselves may not be doing a report, but California Healthcare Foundation does, in the past, I've seen them do some nice policy briefs, kind of going over kind of the regulatory framework between DMHC and the AG's office. So I know some outside groups have, commented on kind of what are the gaps in state law and all of that.
That's a good thought. Okay, any other comments from the board? Thank you very much for your report. Appreciate that. We should take public comment on the item, please.
We'll now take public comment, seeing no hands raised virtually, going to the podium.
Beth Capel, Health Access. Like the board members, we're surprised at how few transactions we're seeing. We will say that high interest rates tend to suppress transactions. We would concur with Dr. Pan that it would be helpful to have an ongoing roster of transactions across all departments. While CHCF has done some very important work in this area, it would have been stronger had there been some ongoing tracking over the last 35 years that the Attorney General has been reviewing nonprofit hospital transactions. And I will also note that no bill on oversight of transactions had been vetoed from 1999 until last fall, when a bill on oversight of transactions involving private equity was vetoed. So rarely does this administration accomplish something the Wilson administration accomplished, but that happened. So anyway, it's not all sweetness and light. So we do appreciate the work that the staff is doing and do think that we could have, part of the role of OCA is to have that more comprehensive picture of what's going on in the healthcare sector. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record, we have about 82 virtual attendees looking to the podium. Seeing no one at the podium, that concludes public comment on that item. It takes us to general public comment.
Open the floor for general public comment.
We'll give it a moment, but seeing no hands raised virtually at this time and seeing no one stepping to the podium, that concludes general public comment.
Thank you to the team, and this meeting's adjourned. Thank you very much.